We are starting the session. Very good evening and welcome to one and all. I'm Srevshi, the assigned moderator from Planet for a seamless experience. Planet is India's most trusted and widely used digital platform with multiple enriching services for doctors. Planet is very proud to be a part as a digital partner for this event, organized by the Association of Maharashtra Obstetrics and Gynecological Societies. And the topic of today's session is webinar on World Population Day. Let's begin today's session, for which I would like to invite Dr. Saman Tamboli ma'am to take over. I'm just sharing her CV deck. Dr. Saman ma'am has done MBBS, DNB, FMAS, IBCLS LC. She's consultant obstetrician and gynecologist at Tamboli Clinic and Max Multispecialty Hospital, Solarpur. She is also international board certified lactation consultant. So over to you, ma'am.
Thank
Kindly
you so
proceed
much.
with your talk.
Good evening, everybody. Since the topic for today is the World Population Day, let me begin by talking something about the World Population Day. The World Population Day is celebrated every year on 11th July, and it was celebrated for the first time in 1990 by more than 90 countries. This celebration began to celebrate to mark the groundbreaking milestone of the global population crossing 5 billion on 11th July in the year 1987. The day is an opportunity to address issues that plague the global population. The theme for 2023 is unleashing the power of gender equality, uplifting the voices of women and girls to unlock our world's infinite possibilities. We must all come together and find ways to build a more just, resilient, and sustainable world. So let's all come together and begin our program. I would like to welcome, for the welcome address, I would like to introduce Dr. Komal Chavan, ma'am. Can you display her CV, please, Shreyasi?
Sure, ma'am, sure.
Dr. Komal Chavan, ma'am, is MD, DNB, MNMS, FCPS, DGO, FICOG. She also holds diploma in reproductive medicine. Ma'am is Medical Director, Chavan Maternity and Nursing Home. She is also DNB teacher and unit head at VN Desai Hospital. She is chairperson AMOG's Family Welfare and MTP Committee 2021 to 2023. She has won many prizes and awards. She is also a peer reviewer for SAFOG Journal and editor of many books and newsletters. Over to you, Dr. Komal, ma'am.
Thank you.
For the welcome address.
Thank you so much. And it gives really a great pleasure to have this webinar specifically on a focused topic, that is World Population Day. And we know World Population Day India has become the largest populated state, and we all are doing our efforts to reduce the population. Each one has to contribute to the cause. And I'm so happy today that this program by AMOGS, that is AMOGS Public Awareness Committee, along with the Family Welfare and MTP Committee, we are hosting and discussing topics, the practical topics related to the population explosion, or how do we control. So this is along with the FOXY, that is Dr. Rishikesh Pai, Dr. Madhuri Patel, and we have Dr. Lakshmi Shrikande, the ICOG chair here. And believe me, the one person who is standing pillar strong in with us is Dr. Rajendra Pardesi, sir. And with his blessings, we are doing all these activity in AMOGS. And I'm so happy and fortunate that we also launched a survey on World Population Day, and it has got a tremendous response by every healthcare provider. We want to know how the people are addressing contraception in their workplace, by any healthcare practitioner, be it a student or be it your workers or be it your staffs, the paramedics. So everybody needs to talk about contraception and needs to be, we all have a collective responsibility. It's not a responsibility of just gynecologists because we are delivering babies or we are the one who are delivering, but the population control becomes a common responsibility of everybody. And that is what we are believing in AMOGS and doing it. Monica, by public awareness, is creating a lot of awareness. And we are trying to update our gynecologists with family welfare and MTP committee on different topics. And Dr. Vandana Gandhi today is going to speak on vasectomy. I think that is an untouched subject and really needs to be heard and addressed. So I welcome you all for a great learning experience. We also had a nice quiz the poster and the slogan contest, and we had our eminent judges also. So results will be coming. Monica will be telling you later. So in all, it is going to be a great webinar. So welcome all the dignitaries, and I welcome Dr. Pardesi sir. Can I have sir's CV? I want sir to introduce sir.
Sure, ma'am.
Sir is the president of AMOGS, and I think he's really the most approachable and the very dynamic president. He has a lot of ideas. He is he works for people. He cares for people, and he knows how to go about in the right way. He can channelize your energy properly. I want Dr. Pardesi sir's CV.
It's okay. It's
yes.
okay,
The second slide.
we can skip that.
Yeah.
Yes. So this is
It's
Dr.
okay.
Pardesi.
It's okay.
Yes. Over to
We
you,
can
sir.
go ahead.
Over to you. We are all waiting.
Thank
to
you,
hear
Dr.
from
Komal, for your kind words. Yes, yes. Good evening, everybody. Respected Chief Guest, Dr. Hrishikesh Pai, sir, Dr. Madhuri Patel, Dr. Sujata Dalvi, Dr. Bipin Pandit, Dr. Lakshmi Srikhande, Dr. Ajay Mane, and our chairpersons, Dr. Ashish Kale, Dr. Richa Sharma, Dr. Priyanka Roy, Dr. Monica Umbardand, and Dr. Komal Chavan. Feeling proud and honored to be a part of this program with Foxy, and also to be with Dr. Hrishikesh Pai and Madhuri Patel, a man with many badlav in Foxy and in public also. As all knows that contraception and family planning is very important, not only in our family, but for nation ultimately, as all policies will be dependent on population only. I congratulate Dr. Monica Umbardhan, Dr. Komal, Dr. Priyanku, Dr. Richa, Dr. Ashish for taking up this initiative on the eve of World Population Day. I wish every success to Dr. Komal Chavan for her future endeavor in Foxy as Vice President Foxy. I wish every success to Dr. Bharti Rajsekhar for her future endeavor in Foxy as Chairperson. I wish every success to Bijay Naik also. Thank you so much for inviting me. Thank you so much.
Thank you so much.
Thank you, sir.
Yeah. Thank you, sir. And I now hand over to Dr. Sanam.
Yes. Ma'am, I will introduce. Actually, I could see Madhuri ma'am, but she's just logged out again.
Oh. We should call her.
I'm trying to call her, ma'am, but she is not picking up her phone right now.
Okay.
In the meantime, ma'am, Lakshmi madam is there. Can I request Shreyasi to declare the results of our competition? I am really privileged to tell you that it was a competition for the AMOGS members, but we have received entries from all over India, and it only shows us the reach that the Public Awareness Committee and the Family Welfare Committee has from all the societies. We have received an entries of more than 80 entries for the slogan and 25 entries for the poster competitions, and each of the posters have been handmade, ma'am. And they are really artistic. We will be displaying the pictures of those who have won the prizes.
Yes.
First, I request Srikhande madam to please say a few words about her experience of judging this competition. Ma'am, thank you so much for accepting our invitation and being the judge at this event on the occasion of World Population Day.
I can see Madhuri madam joining again.
Yeah.
Yes.
Yes,
Madhuri can also listen to the winners list. Madhuri, just 1 minute.
Yes,
Can I declare
Yes,
result first? Madhuri?
yeah, no problem.
So much.
yes, ma'am.
Monica, it was really very tough to judge, as you said, there were so many entries and all the slogans were very good. So at the outset, I would like to congratulate you, the organizers who thought of this slogan competition. You invited slogans, and as you said, you got response from all over India, and we have got slogans in all the vernacular languages. So it was really tough to judge, but as it is a competition, I have to declare some results. So please, don't be disheartened. Each and every slogan was good and very, up to the mark. But I would like to start from the first winner. That was Dr. Shubhi Vittal from Kanpur.
Shreyasi, can we have the slide, please?
Monica, can
Sure,
I?
ma'am.
I would like
Yes,
to
ma'am.
just read her slogan also. जनसंख्या दिवस
Yes,
पर
ma'am.
करें मंथन, रोकथाम पर करें चिंतन, दुविधा को न दे निमंत्रण, जनसंख्या पर हो नियंत्रण. तो Subhi Vittal, congratulations, you have got the first prize. For second prize, there was a tie between Dr. Shweta Manvatkar and Dr. Shobha Patode. Dr. Shweta Manvatkar is from Ballarpur, Chandrapur, and her slogan was एक ही संतान से जीवन सुख शांति.
1 minute. 1 minute, ma'am. Shreyasi, you are declaring the poster results. We need the slogan results there.
Yeah, slogan results.
Ma'am, we have not received the slogans.
I am
I have
reading.
sent it to you to just check. Yeah.
Okay, let me
Just
check
stop,
with my
just
team,
stop
ma'am.
sharing and just listen.
Okay, sure.
Just stop. Yeah, so first, you are all clear ki it was Subhi Vittal from Kanpur.
Yes, ma'am.
Second, there is tie between Dr. Shweta Manvatkar from Chandrapur and Dr. Shobha Patode from Amravati. Dr. Shweta's slogan was एक ही संतान से जीवन में सुख शांति, पुत्र या पुत्री की ना हो कोई भ्रांति. Dr. Shobha Patode has submitted in Marathi. वाढत्या लोकसंख्येला आळा घालूया, श्रम शक्ती, कुशाग्रता, कौशल्य आणि मन शक्ती एकवटून आपला विकास साधूया. So these are two winners for the second slot. And the third prize, again there is a tie-up between Dr. Charu Johri from Alwar and Dr. Anita Malik. So Dr. Charu Johri's slogan was also very cute. जीवन में लिखो तरक्की का अध्याय, परिवार नियोजन का करो उपाय. Congratulations Charu. And Anita Malik's slogan was भारत जन जन का हो संकल्प, धरती बचाओ, परिवार नियोजन ही विकल्प. And Monica, I have taken the liberty to announce one consolation prize, and that goes to Dr. Nisha Sahu for her slogan, आओ भारत को समृद्ध बनाएं, हर दुख दर्द दूर भगाएं, परिवार नियोजन की विधि अपनाएं, सीमित खुशहाल परिवार बनाएं. So these are the results for the slogan competition. I congratulate all the winners and those names who, those I could not take their names. Their slogans also were very, very good. And once again, congratulations, Dr. Rajendra Singh Pardesi, as AMOX president, that you conceived this idea of having slogan and poster competition on the theme of World Population Day. And I must admire the creativity of our Foxy and AMOX members. And thank you so much for giving me the opportunity to judge these slogans. So thank you for having me here. Thank you.
But Dr. Lakshmi, this is the main idea of Monica. So credit goes to Monica Ubardhanka.
Yes, Monica
Sir,
had
it is a joint effort. Yes, ma'am. Thank you, ma'am. It is a joint effort of mine and Komal ma'am regarding the same. Ma'am, I would also like to read out one message from Dr. Kiran sir as a judge for the slogan. He has also declared a special prize for Amravati Society because it has almost sent 25 slogans from the society.
Oh, wow.
So we will also be declaring a special prize for the Amravati Society according to Kiran sir. I also would like to thank Kiran sir for judging the slogan competition. Now I would like to introduce Madhuri Patel ma'am.
Lakshmi madam, just continuation. The idea just comes in our mind and you need a right person to carry forward. And I just discussed this with Monica and yes, I can see my idea working and doing so great. I think, thank you. Pardesi sir just nodding and saying yes immediately and Monica executing it so wonderfully. Thank you. And thank you,
Thank
Lakshmi
you, ma'am.
Madam, sir.
Shreyasi, can we have Madhuri madam's slide, please?
Yes, ma'am.
I'm privileged to introduce our guest of honor, Dr. Madhuri Patel, madam. She is currently the Foxy Deputy General Secretary Foxy. She is also the treasurer of Foxy for the year 2015 to 2018. She has been the joint secretary in the year 2009. She is a joint associate editor of the Journal of OBGYN India, honorary clinical associate at Wadia Hospital. She is the honorary consultant at Police Hospital, Mumbai, a visiting consultant at St. Elizabeth and Maskina Hospitals, Mumbai. She has been the ex-professor and HOD at the PG IMSR MGM College, Mumbai. We welcome you, ma'am, as a guest of honor for this webinar. Please bless us for the same.
Thank you, Monica, for your kind and warm words. Monica has been trying, she's so active in this committee. So I really congratulate you for the same. So
Thank you, ma'am.
respected our Rishikesh Pai sir, President Foxy, then my dear friend, Dr. Rajendra Padesi, President Amox. Then we have today Dr. Lakshmi, Dr. Monica, Dr. Sujata Dalvi, Dr. Komal Priyanko, Dr. Isha, Dr. Ashish, Dr. Amaya, Dr. Bijoy Nayak, Dr. Bipin Pandit, Dr. Bharti, Dr. Vivek, Dr. Ashwini, Dr. Mini, Dr. Aparna, Dr. Purnima, Dr. Anuradha, Dr. Ganesh, and Dr. Mangal. And of course, all of you, all delegates who have joined over here, very good evening to all of you. At the outset, I would like to thank Foxy team as well as the AMOC team, especially PAC committee, family planning, MTP committee of AMOX and the Foxy PAC committee and the family welfare committee for inviting me as guest of honor. And I must say what Dr. Lakshmi has, announced the, results of the slogan, they are excellent. And, we are this way making aware of, all our population also, community also. So this slogan also should go on, somewhere where our community can see this. So it should not remain with the our organization. So we can, put on the website as a committee activity. Foxy has a website. We can, put there. So there are many people. The website is open, so we can, they can access. After certain things, it is not open. Otherwise, our website is open. So I wish that you send to us and we'll put on our website. Secondly, since
Sure,
we are
ma'am.
having a program of population day, because which is the, and all of us are aware that our world population gone to 8 billion and our, India population is 1.43, which has just surpassed the China 1.42. So with the population, increase in population, growth of population, we are also growing. But at the same time, there is a economy is going down, the scarcity of the water, food, everything happens. And of course, the health of everybody, and especially maternal health also affect. So we have to have somewhere, not, I will exactly not say control, but we have to restrict our population. So we don't have scarcity of many things and even the health can improve, not only mothers, but also population in general. So this is very, very important program as far as our gynae OBGYN is concerned. The topic is like tubal ligation, vasectomy, and contraception and MTP, how they can be safe and effective. These are very good topics. And, I really congratulate the organizer for the most apt webinar and wish them best luck. And, I always, like to say, one quote by Nelson Mandela, the education is the best weapon when used can change the world. So dear friends, let us use this education to update ourselves as well as our community, which will help us in day-to-day practice to have a, improve in the maternal health, and we can achieve our target of a sustainable development goal of less than 70 per 100,000 lives by 2030. Thank you once again for giving me this opportunity.
Thank you, ma'am. Thank you so much for your esteemed presence. We are all blessed to have you here. The constant guidance, it means a lot to us. Thank you so much, ma'am. We now move forward. I can see Dr. Shobha Gudi madam has joined, and I would request madam to please share her views on judging the poster competition. We have received as many as 22 posters. Ma'am, how was it judging this competition? Can you please share your views?
Monica,
with
before she start, I want to say hello to Shobha because I could not see on my screen. Hello, Shobha. Okay, if I missed out, please excuse me.
No, there is no there is no problem at all, Madhuri. We are
Yeah.
always there for
Mhm.
each other, and you have
But
always
I have
been
taken each
so
and everybody
supportive.
name.
Yeah.
And Shobha, I could not see, so sorry for that.
Okay. No problem at all. I just want
Okay.
to put in a word that I have had the privilege of working with Dr. Madhuri Patel for the past year during Dr. Shantakumari's tenure, and what a wonderful, supportive Secretary General she is. It was a blessing for all chairpersons that we got somebody such a nice leader to work with, and very approachable, always ready to receive our calls, and she will also give us tips as to when to call her so that she can give us more time. So that was wonderful, Madhuri.
Thank you,
No,
Shobha.
it was a wonderful change to have a woman as a leader there in the office. It was very nice. Thank you so much for the
Thank
support you
you,
gave
thank
us. And
thank
my
you.
greetings to all the honored faculty today. Pardesi sir, namaskar. Always a mentor to all chairperson aspirants. You have guided me also. Thank you so much. Very good evening, Lakshmi. Good evening to you, Dr. Lakshmi Srikhande, chairperson ICOG. Good that you also came to judge, and I am sure the slogan people have really got the best prize because you were there. Thanks to Komal, Richa, and all the other organizers. I can see Monica there. Oh my God, what a firebrand she is. She won't let go till we do the task. And Foxy
Constantly.
needs, yeah.
It was good. We were on our toes. Monica, thank you for your follow-up and
Exactly. That's what I
Thank
wanted
you,
to
ma'am.
say. And I want to congratulate the committees that they have such an active worker with them, both Komal and Richa. And hello, Dr. Nayak, I can see you there. And Anuradha, hi. Priyankur, and Bharti was here and now she is not there. Hi, Bharti. Hi. So, hi, Anuradha. So it's nice to be with all of you.
Ma'am, I'm
See,
very much here,
actually,
ma'am.
yeah, Priyankur, yeah. You have to be there. Without you, it cannot. So the posters were all excellent, were very much in ethos with the philosophy of family planning, and quite a few hand drawings also, and a lot of effort. And it's heartening to see the generation next being so passionate about family planning, and not only focusing on learning endoscopy and learning infertility, etc. So I'm very it was a very pleasant experience, Monica, and very heartening to see the response. Now the first prize, or should we go backwards? Should we go from below upwards? That is
Ma'am,
also okay.
backwards we can declare. Shreyasi, you can now please display the slide that I had given you.
I was
you were
very
showing
keen
to
that
Lakshmi,
the
I was
posters
Yes,
also
yes,
should
ma'am.
be shown. The winning posters also should be shown,
Ma'am, I have sent her. I don't know whether she has made the PPT. If you
Huh.
want, I can, but
Yeah, I
will
think
not
it
be
is important, all the slogans and posters which have won prizes, because when else can they see, right? So here we
Should see
have,
them.
is there one name missing for the third prize? Monica, correct me if I am wrong.
Ma'am, yes, ma'am. Ma'am, Dr. Gupta only. She's the
She is
Deepti
Deepti
ma'am.
Gupta. She is Deepti Gupta.
Yes,
I had given 2 third prizes and 2 second prizes,
Deepti
because
Gupta
I
ma'am
didn't know
and
what
Monica
to
Gupta
do.
ma'am.
5 of them were very outstanding. The first one is Dr. Jyoti Hiregowda. She is from somewhere in I'm not getting, because I didn't get the full CV on that. I only got the names. So the remaining things I'll leave it to the organizers to tell. Her poster is actually fantastic, very comprehensive, and very easy to read. and very representative of all sectors which are responsible for building up a family planning service. So congratulations, Jyoti. And do you have the poster on the slide? No? Monica,
I
no?
sent it to Ritu. Shreyasi, I
See,
sent
Yes,
it
ma'am.
to Ritu.
Yes.
Did she send it? I have sent it to Ritu.
Can you
Did she
show
send
me
it?
the
Which one,
poster?
ma'am?
Dr. Jyoti Hiragauda's.
The poster.
I wanted
Let me
everyone
check.
to
Let
see.
me check, ma'am.
Yeah.
Because I wanted everyone to see. So if time is getting lost, then it is okay. I will just tell off the other prizes. But if you can, you show. Otherwise, speakers must be waiting.
Yes, ma'am. We have received. Just give me a minute.
Ma'am, I will share in the group also. You can talk so that at least everybody else in
Okay,
this group
then
can see.
show me the next of this thing. Slide.
Yeah,
Please.
display the
Finish off the
Shreyasi,
winners'
please display
names
the
at least. Then if you can, you show the slide. I don't want to take more time.
Yeah.
Uh,
The slide that you were showing.
yeah, this fourth slide. Yeah. Yeah, so the
Yeah, this
second
one.
prize, yeah, this is the
Ma'am,
first prize.
this is the poster.
And it begins with the Indian story above, and that's why Jyoti has won the first prize, because she has shown some of the reasons and she has shown some of the solutions. So I found, and she has also included the method effectiveness, and she has tried to make it a comprehensive approach. She has also mentioned the SDG goal, the 2030. The only mistake I see here is actually it is not SDG 2030, it is FP 2030. Family Planning 2030 is the name of the program. SDG is only SDG. I mean, maybe 2030, but when it comes to family planning, it is FP 2030, but it is good. Nevertheless, it is wonderful, and that is why you won the prize, because you showed all the possible reasons and all the possible solutions. So congratulations to you, Jyoti, and I hope you implement all this in your practice. Next, please. Yeah, so the second prize was, this was Unleashing the Power of Gender Equality. This has won the second prize, Dr. Nityashri. And here, I think she has focused on gender equality, which is the theme of this year's WPD. So it is very much in sync with that. She has also mentioned why exactly women are not able to exercise their reproductive rights and what are the problems as a result of that. So congratulations, you have done well. Next, please. Yeah, this also has won the second prize. I came to know that this particular candidate has also won the slogan. Found her.
Ma'am, her slogan is also different, ma'am. So that is why I declared this person.
Okay,
Yes,
okay, good, because she has kind of made it very representative, the gender equality below on a kind of metric disc, and then the pigeon bringing in peace and harmony with family planning, and also the lid to be lifted on population stabilization with the methods inside. So I found it very, very impressive, and yeah, that is how it is. Yeah, I found the caption like no smoking. You saw that no smoking caption where the unwanted pregnancy is put instead of smoking. So that was very attractive and very meaningful. Yeah, down also a lot of meaning, but Shweta, we don't have that much of time. But your poster is very good. I hope you circulate it to many hospitals. Next, please. Yeah, next, please. Yeah. So this was Dr. Ajay Mane's very vehement selection. He said, you have to include this, and I also agree with him. And it is very kind of self-representative. Whatever is told there, all of you can we hope that we hope that this comes true. We all know that we have differences in communal orientation towards family size, and we struggle with it every day in our practices, but we do hope that everyone will feel the same about our country's future in the days to come. Thank you so much, Monica. You have done well. Next, please. Third prize to this, and this I found was a very nice capture by Dr. Deepti Gupta, where actually she has brought in gender equality in a very picturesque way, and she has also named all the barriers for women's empowerment with that chain around the world of women. That was very nice. And she has shown the key lies with the woman herself. The key lies with the woman herself. She should break the barrier and then go and unlock that key. So she has put illiteracy, she has put domestic and sexual abuse, population explosion, other health issues, and also financial. So wonderful. I think these thoughts, and I really congratulate the organizers that they have brought in such a competition. So at least we can see, what our youngsters are capable of and what a refined thought process they have. And thank you so very much for the opportunity to be here. Thank you so much. Komal, thanks a lot. Thank you all.
Thank you so much, Dr. Shobha.
Thanks.
Being the judge, I think it
Thank
was
you,
really
Shobha ma'am.
a decision. Seeing all the posters, they are so lovely. I think really.
And they're all handmade.
Yes. And they're handmade. They have done with so much creativity. So that is really great. So thank you. Thank you so much, Shobha madam. I think Monica has lost connection. Is she there?
Yes.
Yeah.
She's there but lost connection.
Hello,
Yes.
ma'am, am I audible?
Yeah,
right
yeah,
now?
you're audible now. So I think I was just thanking Dr. Shobha Guri madam and Dr. Ajay Mane sir. I think that this was very close and very good decision, such handmade, lovely posters. And I think in Amox, in front of Pardesi, we'll really be looking forward to circulate these posters and put it on the website. Madhuri madam also has said. So these posters should be displayed and we need to circulate among our members and put it in hospitals to raise awareness.
Komal, even slogans also, they were too
Yes.
good.
Sure,
The
ma'am.
slogans,
We
they
will
should
be putting, I think, with Amox logo
The
and with
slogans are
the,
very catchy, I think.
yeah,
Yeah.
with the committee name, I think we should make a banner or a poster and we can distribute to, the hospitals and they can put this because we all do counseling and when we have such slogans, it will become more easier.
Yeah, all the 6 slogans in one poster with their names and place. So, I mean, it will be really good.
Yes.
Sure, ma'am. Ma'am, we have a website and we have a public awareness committee page on the Amox website. So we will display all the pictures there definitely, ma'am.
Great, great.
Thank you
Yes.
so much.
Thank you so much, Shobha ma'am and Lakshmi ma'am, for judging the competition and for being prompt with your results, ma'am. I know it was very late to send you the entries. It was 18th almost. Thank you so much, ma'am. We now move forward for the academic session. I take privilege in introducing our chairperson, Dr. Priyanka Roy, who is the chairperson for FOXI Public Awareness Committee, and Dr. Bijoy Nayak. Can I have the CVs, please? Shreyasi?
Yes,
I
ma'am.
take privilege in introducing Dr. Priyanka Roy. He is currently the chairperson of Public Awareness Committee. He is a consultant at the Nova IVF and the Royce Clinic, Siliguri. He is also the India representative to WATOC. He is a FIGO Joint Secretary of Gestrosis India chapter. And this is an old seat, I think. Priyanka, he has become the VP of WATOC now. Thank you. Dr. Bijoy, slide, Shreyasi.
Yes, ma'am.
I can't see the slide, Shreyasi.
Yes, ma'am. Just give me a minute. I'm
The next slide, please. It's still not seen. Dr. Bijoy is the head of the Department of the Minimal Access and Robotic Surgery Gynecology in New Delhi. He heads the department in the Manipal hospitals. He is also the chief gynecologist at Fortis Hospital, the head of the department of the EMRI hospital. We welcome you, sir. He has been the chairperson of the endoscopy committee and the founder president of the Bhubaneswar Society. His research projects include gut and tubal ligation, and he has the state government of Odisha felicitating him the award for the extensive research on degrees of adhesion present with or without peritoneal closing cesarean section. We welcome you, sir, as the chairperson for this session. I request Priyankur to introduce Richa ma'am and Vijay sir to give the concluding remarks after the Richa ma'am's talk, please.
Thank you, Monica, for that introduction.
Monica.
So first of all, I would like to thank the AMOX PSC and the Family Welfare and MTP Committee of AMOX and of the Family Welfare Committee of FOXI for giving us this opportunity for PSC to be associated in this excellent webinar. We all know World Population Day, of course, is a day which is celebrated worldwide, but for India currently being the most populous country in the world, we have to take measures such that this Population Day at some point of time becomes a matter of pride and enjoyment for us as well. So we have seen the results for the excellent slogan and poster competitions, and I'm sure these slogans and poster at some point of time when put in the hospitals of different doctors, as has been talked by our seniors, will bring a lot of motivation to everyone for better population control. So with regards to my co-chairperson, Dr. Vijay Naik sir, very respected senior, I would like to first of all introduce Dr. Richa Sharma ma'am. Can I have the CV slide, please? So Richa Sharma ma'am is currently the chairperson of the MTP Committee of FOXI. She's a professor at the UCMS Hospital in Delhi. She is the national corresponding editor of the Jogi Journal. She's the IAGE Managing Committee member and also editor of the IAGE newsletter. She's an excellent academician, has been trying a lot towards spreading knowledge of MTP across the country. So we have had a number of panels where we have been a part of with Richa ma'am at the helm as a moderator. She has received a number of awards and a number of prizes, as you can see in this list, and has more than 75 publications to her credit. Ma'am, the stage is all yours. We are here to listen to your talk on complete guide to tubal ligation, which I'm sure will help us in improving the population status of the country towards betterment. Over to you, ma'am.
Thank you, Dr. Priyankur, for the kind introduction. Good evening, everybody. My regards to the AMOX President, Dr. Rajendra Pardesi sir, and my regards to the Lakshmi Shrikhande Madam, Dr. Madhuri Patel Madam, and Priyankur and Dr. Ashish Kale for giving me the opportunity. And thank you, Dr. Komal Chavan and Dr. Monica. You are doing really wonders. And my best wishes to the contestants who have joined today. Dr. Komal Chavan, best wishes to you, and Dr. Vijay Naik sir, best wishes to you. Both of you are contesting for the Vice President election, FOXI. So with this permission, now I start. So now I start my presentation. I bring greetings from UCMS and GTB Hospital, Delhi, and also from the FOXI MTP committee. Okay, so I will be talking about the female sterilization for another 15 to 20 minutes. So now we all know Madhuri Patel Madam has also said that we have surpassed China's population. Now India is #1 in population, although the size is 7th in the world. Now we can see we are 142.9 crores compared to China, which is 142.6. But then the good news is that the India wins the prestigious Excel Award, the Leadership in Family Planning by ICFP 2022. And the National Family Health Survey, that is 5 data, it says that the overall contraceptive prevalence rate has increased from 54% to 67%, and the unmet needs for family planning has declined from 13% to 9%. So let us hope for the best. So now coming to the topic of permanent sterilization, that is a female sterilization. Now we all know there are the 2 acceptable procedures by the government of India, that is the mini lap tubectomy and the laparoscopic tubal ligation. These are the most acceptable ones. And although they are permanent, but still the failures are always there. And the mini lap tubectomy and the laparoscopic tubal ligation, they have a small risk of failure, that is 5 per 1,000 in the first year of ligation. And then there is again a small risk of pregnancy remains up till the lifetime, till the menopause of a woman. And after 10 years of the ligation, also the risk is 18 to 19 pregnancies per 1,000 women. So the effectiveness, actually, it depends upon the type of ligation and the skill of the operator, which is very, very important, and the case selection. And it has been found that the most effective method is the postpartum tubal ligation, wherein we are ligating and excising the tube. Now, who are the doctors who are eligible to perform the sterilization procedure? Now, the doctors who are impaneled for performing the sterilization operation in the public or the accredited private or NGO facilities. And if the doctor is impaneled with one state or the district of India, then he or she is eligible to perform the sterilization operation in other state and the district of India. So in the cases of mini lab sterilization, now the PG degree or a diploma holders in the Obs and Gynae, they are eligible to do the mini lab, and also the specialists in the other surgical fields. And also the MBBS doctors, provided they are trained in the mini lab sterilization. Now training means they have observed 5 cases and they have performed 5 cases under supervision. And the laparoscopic sterilization, again, the PG degree or a diploma holders in Obs and Gynae, or the specialist in other surgical fields, and also the MBBS who are doing the mini lab sterilization and they are trained in the lab sterilization, again means they have observed 5 cases and they have performed 5 cases under supervision. So they are entitled to do the sterilization procedure. Now the eligibility criteria for the patient is very, very important. Case selection is very important. Now there is no eligible client should be denied from female sterilization services. So there are 6 most important eligibility criteria. That means a patient or a woman should be ever married, or she should be between the age group of 22 to 49 years, and couple should be having at least 1 child of more than 1 year. Unless the sterilization is now medically indicated, then they cannot also. And then the 4th point is that the woman or the spouse or the partner, they must have not undergone sterilization in the past. And this is also applicable in the cases of failure of previous sterilization. Now, the woman should be sound state of mind and she should be able to understand the complications and the implications of sterilization, and she should be ready for the follow-up. And then patient, if she is mentally ill woman, then she has to be certified by the psychiatrist. And then the statement should be given by the legal guardian or the spouse regarding the soundness of the mind. So actually the no medical condition prevent a woman from undergoing female sterilization. But then there are certain conditions where we have to be cautious, where we have to delay the procedure, or we have to treat it as a special category. Now the timing of the sterilization is very, very important. Now, why am I talking so much about the eligibility of the doctor, eligibility of the patient and the timing? It is because the family planning indemnity scheme is there, because if there's a failure of ligations, then the compensation is given to the patient and also the protection is to the doctors, which I'll be telling the next. Now, most important is a postpartum sterilization. So you can do the sterilization within 7 days of the delivery by PPS, that is a postpartum mini lap tubectomy. Laparoscopic ligation is contraindicated in the postpartum women. Then sterilization after the MTP or the spontaneous abortion, we can do within 7 days or concurrently. And after the MTP, if we are doing MTP in first trimester, then we can do the sterilization by laparoscopy or mini lap. But in the second trimester, we have to do only mini lap sterilization. Laparoscopic is contraindicated. Now, if we are doing the MTP by medical method of abortion, then we have to do the sterilization in the next menstrual cycle. So for that cycle, you can give some temporary method of contraception. You can give the hormonals also, injectable implants or tablets you can give. You can club it with the Misoprostol tablet. Then sterilization can also be done concurrent with other surgeries like cesarean, salpingectomy or cystectomy. Now, most important is the interval sterilization. Now, when we should do the interval sterilization? This we can do within 7 days of LMP or any time when the patient and the doctor, they think that the patient is not pregnant, because pregnancy has to be ruled out before you do the ligation. So if the patient doesn't have any signs and symptoms, or she had not had intercourse in the last menses, or she has been correctly using the reliable contraceptive method, she is within the first day of the post-abortion or within the first 7 days after the onset of menses, or within 4 weeks postpartum, or she is in lactational amenorrhea. So in those cases, we are sure that patient is not pregnant. Now, case selection is very, very important. We have to do a thorough history taking, physical examination, and the lab investigation so as to ascertain the eligibility criteria. Now the routine investigation, now the HB of the patient should be more than 7 grams. And at least the urine examination for albumin and sugar should be done. And ideally, the recommendation is that we should do the ligations under the local anesthesia. So other investigation, usually it is not required, but then you have to individualize as per the case, and you can ask for the other investigation also, depending upon other comorbidities. Now, the preparation of the patient prior to the surgery is very important. You have to maintain a nil peroral status. A proper counseling also is very important before you take up such patients. So you have to ask that patient should be fasting. She should not have taken any liquids 4 hours prior to the surgery, or any solid which includes milk and tea for last 6 hours prior to the surgery. Pre-medication is same as we are using in the other cases also. Either you can give Alprax tablet or diazepam. And local anesthesia, what I've told, it is the most acceptable for both mini lap tubectomy and as well as laparoscopic tubal occlusion. And the local anesthesia, most appropriate, it is a lignocaine, but we have to use it very carefully. It is 3 milligrams per kg body weight. And the onset, we all know it is 3 to 5 minutes, and the duration of action is up to 45 minutes, which is just appropriate, or it is more than appropriate for doing your procedure. You have to dilute the lignocaine. Now, this is for the beginners. You take 10 ml of 1% lignocaine is adequate. So you take 2%, you have to dilute it, normal saline or the sterile water. Then other drugs which you can use as the preoperative and intraoperative sedation or analgesia. There are a lot of drugs, but whatever is recommended as per the Government of India guidelines, we have to use according to the body weight, which is pethidine or promethazine or pentazocine or promethazine we can use. And we have to titrate the dose according to the patient weight depending upon their BMI. Okay, so next is the surgical approach. Now, I have already told now the 2 procedures are most acceptable as per the standards. One is the mini lap tubectomy and another is the laparoscopic tubal ligation. Now, laparoscopic tubal ligation, the most recommended is the Fallope ring tubal occlusion. Now, in the cases of mini lap tubectomy, if we are doing, so that there are the 2 approaches where we can go. That is a subumbilical approach. We all know we have to do in the postpartum uterus within 7 days of the delivery, wherein your incision should be just below the upper border of palpable uterus. That is in the cases of postpartum sterilization. And then another approach is the suprapubic approach, wherein you consider in the cases of interval mini lap tubectomy, and your incision will be 2 to 3 centimeters above the border of the pubis. Now, the choice is yours. Either you use vertical or transverse, but the transverse certainly had the good results. We all know cosmosis, and also the complication is less. Now, the basic procedures, I am not going into the details. Each and every one we have been doing mini lap tubectomy, laparoscopic tubal ligations. They are the very basic procedures. But then there are few tips which I just want to highlight so that the failures does not occur. Now, the basic principles of a modified Pomeroy's technique in the cases of mini lap tubal sterilization is that always use an instrument that is a Babcock so that you can make a good loop of it and you elevate it to about 2 to 3 centimeters. And what will be the place of placement of your Babcock is 2 to 3 centimeters from your cornual end. So actually you will be picking up the ischemic part of it. And what you have to pick up is the mesosalpinx. You should not be holding half of the tube or just from the tip of the tube. You have to hold from the mesosalpinx, which is an avascular area. And then once the loop has been created, then you put the stitches and then you have to excise that. And you excise in such a way that at least 1 centimeter of the tube is excised. And then the margins are also there so that whatever ligature you have put, it does not slip and the tubes also fall apart. So the suture material, which is most ideal, what is recommended is the absorbable suture, chromic catgut, which we have to place around the loop also. And then of course, the minimum tissue handling and destruction is most important in all the surgeries. Now coming to the lap ligation. Now lap ligation, we all know it has to be done with the laprocator. You can see the prongs. And again, the principle of basic principle of laparoscopy has to be followed. And then the site is the same. Again, you have to pick up the tube at least 2 to 3 centimeters from the uterotubal junction and put the fallope ring. Now, what is more important in that, you can see the picture also. Once you put a loop, once you put a fallope ring, now the tube should get the blanched. Now the entire tube should be within the ring. It should not be half, because if it is half or just crush the tube, that means the failures will be there. So a good segment of the tube, as you all can see in the picture. So this will avoid the ligation failure. And another important thing is about the fallope ring. Now the memory is very small, so do not leave the fallope ring into the ring dilator for more than 5 minutes. And never dip it in the spirit or alcohol. If at all you want to lubricate it, do it with the local anesthetic, whatever is remaining, or even the sterile water also. So these are the few basic tips. And of course, you have to follow the principle of laparoscopy, and also you have to monitor the patient pre-op, intra-op, and post-op. Now, most important part of any surgery, we all know, is the monitoring. We have to maintain a good medical records. Because why we have to maintain a good records, why documentation? It is again because of the family planning indemnity scheme. Once the patient comes with the failure of ligation, now the whole paperwork, all the case sheets will be scrutinized. All the papers will be scrutinized, whether the patient is eligible for the reimbursement or whether the doctor also is impaneled. So we have to give a good record of it. And at the end, I'll be showing you all the forms which has been given by the ministry. So medical record, you have to maintain, you have to monitor the vitals, the level of consciousness, and then you have to document if any drug you are giving and the time and the dose and the route, everything you have to document clearly. And pre-operatively, once you have given the pre-medication, ideally the columns are there, you have to monitor every 10 minutes. And then intraoperatively, we assume that you are doing the ligations under local anesthesia. And but then again, this is your discretion. Some people, they opt for general anesthesia, so you can individualize it. But what is more recommended is the local anesthesia. Maintain a verbal communication with the patient. They also feel confident, and they also feel less pain. That is a vocal local. So vital charting has to be done intraoperatively every 5 minutes, and especially when you are insufflating the gas and at the time of ligation. And then post-operatively also, you have to maintain the charts, and monitoring has to be done every 15 minutes for at least 1 hour after the surgery if the patient is fine, or you will have to increase the monitoring and the treatment if the patient is having any problem. Now, when do you discharge the patient? Now, we assume it is done under local anesthesia. We have monitored the patient for about 1 hour. And then after 4 hours, you have to discharge the patient if everything is fine. Now, everything fine means the patient vital signs stable. She is fully awake. She has passed urine. She can talk to you comfortably. She can drink and she can walk. But always discharge the patient with some relative. Don't discharge the patient. Don't let the patient go home alone, even if she is fine. So that is very important. And the warning signs, of course, like in other surgeries, you have to explain to the patient also the warning signs when she has to contact the doctor, when she has to come immediately to the hospitals. Now, the warning signs can be because of the complication of the anesthesia or the complication of the surgery, if at all. So it starts from the dizziness with fainting, or there is abdominal pain or a persistent bleeding from the site, or the cramps which is not getting tolerated, and then vaginal bleeding or the shoulder pain. So you have to explain the patient very carefully. So again, the counseling is very, very important. Pre-operatively, or when the patient opts for ligation, you have to counsel her, although it is a permanent method, but then still the chances of failure are there, which are very less. And so she has to come for the frequent follow-ups also. So you have to counsel the patient. And then advice on discharge is very important. You have to give a set of advice. You have to be very specific, because the patient, they have small doubts and the queries, and then they don't know how to go about it. So the government of India also, they have given a chart. I will be showing you the written advice. You have to give them and you have to explain them verbally. And so patient, they can take a rest up to 48 hours, and they can do a little bit of light work also after 48 hours. But then certainly they have to avoid carrying heavy weight for at least 1 week. And slowly they can return to their activities within 1 week if they are not doing any hard work or the heavy work. Medications and antibiotics, that is your discretion, and patient can take the normal diet as soon as possible. And then she has to keep the incision site clean and dry. And whatever dressing you have put, either you have put a Dynaplast or you have put any bandage, whatever has been put, she doesn't have to change again and again till she comes for suture removal. Or if you have put any absorbable suture, but if it has become wet or there's a soaking or anything, then she certainly has to change her dressing. And she should take bath after 24 hours. We have to tell them, because there are the patients, they don't take bath and then they come after 1 week or they come for follow-up and they say we have not taken bath because of the stitches. So we have to explain to them they have to take bath. They can take bath after 24 hours. And of course, warning signs, very important. They have to be very clear with that. And the most important thing is that the patient, they have to return to the hospital if they don't get the menses in 2 weeks, which is very important. This we have to clearly explain to them. Now, if the patient is living in the periphery, then she has to contact her health workers within 2 days. Now, most important is the intercourse. Now, always the patient asks when they can resume the intercourse. So we have to tell them if they have undergone sterilization after cesarean or a normal delivery, so in 2 weeks. And if it is a mini lap or laparoscopic interval sterilization, so after 1 week, they can have intercourse, provided everything is all right. Follow-up visit is very, very important. There is a chart also wherein you have to document the follow-ups, because sometimes what happens, the patient, they can report after 8 years, 9 years with ligation failure. So follow-up visits are very important. So the first follow-up is after 1 week of the surgery or as early as possible after 7 days. Second follow-up is after 1 month or after next month menses, whichever is earlier. And she has to come for follow-up if there is no menses in 2 weeks. So we have to explain to them very clearly. Now, the certificate of sterilization is another important thing. Now, the certificate has to be issued after 1 month of the surgery or after the next menses, whichever is earlier, and the patient comes to you. Now, if the patient had no menses, even after 1 month of the surgery, we have to rule out the pregnancy before we issue the sterilization certificate. Now, sometimes what happens when we do the sterilization, either by mini lap or by tubal ligation, and suppose we are not able to hold the tube or we are not able to do a proper ligation, in that case, we have to document the failure of the procedure. We should not hesitate in that. If the half tube is ligated, that means she will fail. So we have to correctly identify that the procedure has failed, and we have to tell the patient also, and we have to get their counter signature in the document that you have informed the patient that the procedure has not been adequately done. And in that case, the sterilization certificate should not be issued even if she resumes the menstrual cycle, until unless you have done the proper ligation. So these candidates where you have not done the proper ligations, so these are not the candidates who are eligible for compensation under the FPIS scheme. And this is a sterilization certificate format, and which you can also download from the 2014 manual of female sterilization manual. Now, documentation part, now it is very, very important, because again, FPIS scheme is covering the ligation failure. So documentation is very important. Now, this is the document we have to fill. I assume it is not very clear, but then again, you can download it also from the manual 2014. So most important, it is a 3-page of the application cum consent form of sterilization operation. So here, all the details you have to fill about the patient. It gives a detailed counseling part also is there, what you have to explain. You have to clearly write the name of the patient. And then you have to get the signature of the witness from the client side. This is very important. So it is a 3-page document which you have to fill. And then next is the medical record. Now, whatever I have spoken about the medical record charting and monitoring and everything. So this is some 7-8 pages medical record and checklist which you have to fill, and which clearly tells you about the eligibility checklist. You keep on ticking it and you have to fill that. So it is a 8-page document almost. So intraoperative, preoperative and post-operative monitoring also chart is there. You have to fill everything because it will go into the patient case sheet. Now, the doctor who has done the ligation, the name will be there. The doctor who has discharged the patient after checking the vitals and everything, her name also will go here. So you have to be very, very clear. The signatures has to be there in all the pages. Then next, most important thing is the post-operative instruction card. Now, whatever instructions I have discussed with you, the advice on discharge, the warning signs when they have to return for the follow-up, this is a post-operative instruction card. You can also make your own card, but just remember to include all the points. Follow-up visit is very, very important. Do include that visit also and clearly explain to the patient. And then the signature of the patient, signature of the person is there, whoever is filling this report. So that person is also responsible. Now the family planning indemnity scheme. Now the new scheme says there are the various sections, which is 1A, 1B, 1C, 1D, and 2. So now 1A means if there is a death which is attributable to sterilization procedure in a hospital or within 7 days from the date of discharge from the hospital, so they will get rupees 2 lakhs. If death is attributable to sterilization within 8 to 30 days from the date of discharge from the hospital, then 50,000. Failure of sterilization means 30,000. And the cost of treatment in the hospital and up to 60 days arising out of complication is attributable to sterilization operations. So they will be getting 25,000. Now we all are protected. Ideally, we should not be doing the ligation if we are not impaneled. So indemnity per doctor, per health facility, but it is not more than 4 in a year. So maximum you can do up to 4 failures in a year, but you are covered up to only 2 lakhs per claim. So that is very important. So what I said, 5 cases you have to observe, 5 cases you have to do, but then you should be confident enough and you have to be that you can do the procedure. Then only you should undertake the procedure. Now, how if the patient comes with the failure? Now, patient can come with the ectopic pregnancy, then also she is entitled for claim. Or if she comes with intrauterine pregnancy, that means if patient comes with UPT positive, she is entitled for claim. But she has to come to the same health facility from where she had undergone sterilization operation, and she has to report within 90 days or 3 months of the pregnancy or any complication, failure or death, whatever they want the claim. So the claim is very simple. Once the patient comes to the hospital, whoever was a treating doctor, that is a CMO or the hierarchy, and then also the joint director. So they will process, they will authenticate the claim, they will process it, and ideally they have to complete the filling of the claim documents and everything within 1 month. And then it will be evaluated by the DQAC, that is a district authority, a district quality assurance committee, and then it goes to the state quality assurance committee. So it will be evaluated. So evaluation means the entire case sheet will be checked, all the forms which you have filled, it will be scrutinized. And if everything is in place, all the signatures, all the steps, everything has been filled, then only the patient will get the compensation and you will also be protected. So the stipulated time limit for settlement of that claim is 15 working days in case of death and 21 days in case of others after submission of all the required documents. So this is about the family planning indemnity scheme. So once again, I repeat, you have to be impaneled. Now, this was our study. This was done, this was a 5 years retrospective analysis, what we had done in our tertiary care teaching hospital at UCMS and GTB. And this study was published in the Journal of SAPHO 2017. Now, here in this, we had evaluated the 5 years of all the ligation failure cases. And we had 59 ligation failure cases in 5 years. So when we evaluated the risk factors why the patient had failed, and the few ligation failure they had reported even after 10 years also. So when we evaluated, we found that majority of the ligation failures were previous 1 or 2 cesareans, and there were the difficulties intraoperatively in dealing with the tubes. And third was the grade of the operator's skill. So we have in the teaching hospital, we have the junior resident, senior resident, everything. So when we evaluated, then we found that certainly the cases of failure was less in the experienced hands. So that was another thing. So what I recommend, it is not that we should stop teaching our juniors or the junior residents or senior residents, but it has to be supervised. So that is very important. And so finally, I conclude by just a few take-home messages that the eligibility of the doctor and the patient is very, very important. And case selection is very important. And the documentation I have told you, and the follow-up visit is very important. We have to give a proper advice to the patient. She has to come for the follow-up. And if she has come with a failed ligation, even if you have done, we should not feel bad. We should not hesitate, but we should help the patient to get the claim. So that is very important. So this is a reference manual for female sterilization 2014. So you can download the forms from this. And so thank you so much. Thank you for your patient hearing. Once again, thank you, Dr. Komal and Dr. Monica, for giving me the opportunity. Thank you so much. Hello, Bipin sir.
Thank
Good
you,
evening,
ma'am.
sir.
Good evening.
Hi,
Vijay
Pandit.
sir,
Good
can we have your
evening.
marks?
Yes, good evening. Good evening to everybody. Dr. Pandit, good evening. And what
Thank
is
you.
what
Good
a
evening.
lucid talk by Dr. Richa. It's a beautiful talk pertaining to all the things in sterilization. It has given the remembrance of my working with sterilization. I have done around 70,000 sterilization in the camps. And the highest I did single-handedly in a single day, it was 250 cases single-handedly within 12 hours. I was just remembering those days of mine. And thanks, Richa, you have so much told about those sterilizations, all the aspects of the sterilizations. And it's a really lucid talk. Thank you, Richa.
Thank you, sir. Thank you so much, and best wishes, sir, for your upcoming elections.
Yeah, so Richa ma'am, thank you so much for that wonderful talk.
Yes, thank you.
Yeah, you very vividly covered, ma'am, the very important aspects, of course, of tubectomy, and that's one of the impactful talks, I would say, in today's day. And we have a lot of delegates with us, I'm sure, who will benefit from this talk. So thank you so much once again. And I would especially like to thank Komal ma'am, for Monica and Ashish for giving me this opportunity to be here. And I would like to wish all the best to Komal ma'am and Vijay Nayak sir for the upcoming FOXI elections. And also, of course, Bharti Rajshekar ma'am as well for the chairperson election as well. Sure. Thank you.
Thank you, Priyanka.
Thank you. Thank you, Vijay sir, and thank you, Priyanka, for chairing this session. Thank you, Richa ma'am.
Monica.
It
Thank
was
you,
an
Monica.
exhaustive talk.
Thank you, Monica.
We now move forward to the next academic session. Our chairpersons for the next academic session is our Dr. Bipin Pandit sir and Dr. Bharti Rajshekar ma'am. Tracy, can we have the slides, please? Dr. Bipin Pandit sir is a past executive council member of the Maharashtra Medical Council. He has been the vice president of FOXI in the year 21-22. He has been the past president of Mumbai OBGY Society, the past joint secretary of FOXI, and the treasurer at AICOG 2013 Mumbai. He has also been the past president and trustee of the Association of Medical Consultants Mumbai. He has received a Lifetime Achievement Award from the AMC in 2019. We welcome you, sir, as the chairperson for this session. I also take privilege in introducing Dr. Bharti Rajshekar ma'am. The next slide, please. She is the coordinator for the Public Awareness Committee in the South Zone. She's also been the state vice president of the Indian Red Cross, Hassan. She's also at the IMA state vice president, Hassan past secretary, president, as well as the secretary of the Hassan OBGY Society. She has been a member of many FOXI committees, including the Preventive Oncology, the Food, Medical Equipment and Drug from the Public Awareness Committee. She is a trainer at FOXI Dhira program and the trainer at the FOXI RSE program. I request Bipin sir to please introduce our speaker, Dr. Vandana Gandhi madam, and Dr. Bharti madam to please sum up the talk after that.
Thank you very much, Dr. Monica. I must thank Dr. Monica and Dr. Komal and Dr. Pardesi sir for giving us this opportunity. And after the beautiful lecture up by Dr. Richa Sharma on female sterilization, now we are coming to the male sterilization topic, the nuances in vasectomy. May I have the slide of Dr. Vandana Gandhi, please?
Sure, sir.
Please share it. Male sterilization, unfortunately, is not very popular in the population. Many a times we come across patients. They say, "Inka operation mat karo, mera jo karna hai karo." So females are only preventing their husband from getting operated there is a fear, there is a psychological problem that if they get operated, there'll be problem. But it's not true. What is most important here is to do proper counseling, proper consent to be taken. Fortunately, the male sterilization reversal is very easy compared to female sterilization. It is a very easy operation to be done in local. And if we convince the patients properly, of course, it will help. Now, Dr. Vandana Gandhi will tell us about the nuances. She's a founder of Female Fetus Protection Group, Save Girls Counseling Center, ACLUS, and she's a founder of AOGS 2013 and president of AOGS 2018 and 19, and member of the Contraception and Family Planning Committee, MUGS 2018 and 20. I am on the board of Family Planning Association of India, which is headed by Dr. Sonawala, and we have almost 43 centers. So we try to motivate people for male sterilization, but unfortunately, the number is very less compared to female. With these few words, Dr. Vandana, please proceed.
Thank you, sir. Thanks for the introduction. And give a minute. I cannot share my screen till the other screen is stopped.
Shreyasi, can you please allow ma'am to share her screen?
Yes, ma'am. I have stopped sharing my screen. You can proceed, Vandana, ma'am. Yes, yes.
Yeah.
Yes, your screen is visible. You just have to make it full screen, ma'am.
Just a minute.
Make it slideshow. Yeah.
Ma'am, the screen is visible. You can start
No,
talking
my
now.
cursor was not moving.
Yes, ma'am.
Okay. A very good morning from Canada and good evening to all of you. And to today's World Population Day, should I say it is I'm actually puzzled. Should I say that are we celebrating this World Population Day? Or are we regretting that there is an explosion of the population in the world? Are we mere discussing because it is a day to celebrate? Or are we finding solution? Can you help me? This ribbon of the screen sharing and all the buttons is not going. Or are
they are not visible here.
Okay. I'm not if it is not visible, that's okay. Or are we planning how to stop regretting the past decisions and our mistakes? So today we are discussing to find out some solutions. Vasectomy, always neglected, that we know, and Dr. Bipin Pandit sir has very straightforward said that we have a great failure on this part, that they are very less in number. So what, as a gynecologist, we need to know about vasectomy? The theme of 2023, according to United Nations, is the theme for the year of World Population Day, unleashing the power of gender equality, uplifting the voices of women and girls to unlock our world's infinite possibilities. So with this theme, we should know what is the population currently. So the global population in this year is 8 billion plus, and there is a 0.88% increase from 2022. If we see this ascending chart, in 12 years, we have ascended to 7 billion to 8 billion. In next 15 years, we will go to 9 billion. And in next 20 years, we will touch 10 billions. That is what United Nations say. So already it is exploding, and that's why we are here, how to control in our way.
We being gynecologists are an important responsibility of healthcare system, and we must know this aspect of reproductive health to help the population control and related social stability in a broad spectrum. So what is the role of gynecologists in women healthcare? We should know some facts about that. Vasectomy, what a gynec needs to know. First, we must accept the fact that usually males try to avoid and keep neutral when we counsel about the topic of family planning. Many times the couple doesn't come, only the wife comes, or if at all the couple comes, then it is a very difficult counseling part to the husband. Secondly, we all gynecs are okay if they easily accept for tubectomy. Means once they accept some method, we are okay because we are going to operate them. And we don't take much efforts because we had bad experiences of counseling from the counter male part. Are we taught to perform vasectomy in our PG curriculum in gynecology? Sadly, no. At least to me, I was PG in 1990s and we were not taught, even we have not seen a procedure when we were PG students to know about the family. So we were only concentrated on tubectomy part. So vasectomy is usually neglected by all males as well as gynecologists. Points we need to review today is to define and purpose of the surgery, to know the history and anatomical understandings, the social scenario and the statistics about current strategies and facts, medico-social aspects and myths, and suggested protocols. So to define vasectomy, it is a surgical method of male sterilization for permanent birth control, which cuts the supply of semen, supply of sperms into seminal stream. It is done by cutting and sealing the tubes. It is done by cutting and sealing the tubes that carry sperms, that is vas deferens. Vasectomy has low risk of problems and can usually be performed in an outpatient setting under local anesthesia. The first recorded vasectomy was performed on a dog in 1823 by Cooper from England. Henry Sharp performed the first vasectomy in 1899 for non-medical reasons on human. The purpose behind procedure was to stop a 19-year-old boy from masturbating too much. R. Harrison of London, a professional barber, performed first human vasectomy in 1924. It was done to stop the prostatic function, what is mentioned in the history. By 1971, vasectomy had become an accepted method of birth control, preferable to female sterilization because there was less risk associated with the vasectomy and a shorter recovery time. In 1974, in China, the no scalpel method of vasectomy, or what it is popularly known as NSV, was developed by Dr. Li Shuqiang, who was looking for a way to perform the procedure that would be more readily acceptable to men, as Chinese men did not widely accept at that time. By 1985, the NSV method was made its way into America and was performed by a doctor who went to China to this doctor specially to study the procedure. Dr. R. Harrison of London performed the first human vasectomy, not for sterilization purposes, but to bring about the atrophy of prostate. During the Second World War in mid-19s, during 1939 to 45, vasectomy was finally regarded as a method of birth control. And for our Indians, the first vasectomy program on a national scale was launched in 1954 in India. So from independence, or from 1954, we are 69 years plus, and still we have not been succeeded in making vasectomy as a general procedure in family planning programs. To consider the anatomy in brief, The vas deferens is 45 centimeter long tail of epididymis in scrotum, from where it ascends posteromedial to the testes and epididymis. It travels superiorly through the inguinal canal as a part of spermatic cord. This long muscular tube runs from the epididymis into pelvic cavity behind the bladder and connects to urethra through a structure called as ejaculatory duct. So in this figure, we have seen too many times the anatomy, but to know the root of the vas deferens so that the operative site can be decided. The surgical anatomy, if we study, it is a very superficial part of the vas deferens. Before it enters the inguinal ring or inguinal canal, is just under the skin. Here it is shown by an arrow. So it is subcutaneous part and accessible to the surgical procedure. It is in the spermatic cord, so we have to palpate the vas deferens and we have to locate. The surgical technique involves to palpate and locate the vas deferens after giving a local anesthesia, to pick it up with a clip forceps and to take it from out of the skin for ligation. This small video will explain the steps. I'm sharing this video because it is easily available on net. We can use ourselves to counsel our patients, and we should know how easily and how nicely they have demonstrated.
A vasectomy is a simple surgery that works as a permanent birth control method for men who no longer want children. The male reproductive system includes the testicles, two oval structures where the male reproductive cells, sperm, are produced. Each testicle connects to the vas deferens, which are spaghetti-sized tubes that carry sperm to the urethra, a canal in the penis that carries urine and sperm. A vasectomy is a procedure in which the surgeon cuts and seals the tubes that carry sperm, so that the man's ejaculate no longer contains sperm, only seminal fluid. To start the procedure, the patient will be given a local anesthetic by injection to numb the area, meaning he will be awake the entire time, but will feel no pain. In a conventional vasectomy, a scalpel is used to make a small cut on the side of the scrotum, which is the bag of thin skin that contains the testicles. The doctor will locate the vas deferens and lift it through the cut made. At this time, the patient may feel a slight pull. The vas deferens will be cut and a small part will be removed. Later, the ends of the vas deferens cut will be tied, sealed, or ligated with surgical clips, and once this is done, the vas deferens will be placed back in the scrotum. The suture will be made, and these same steps will be repeated on the other side. This procedure takes approximately 30 minutes. A vasectomy can also be performed without a scalpel. Instead, a special ring clamp is used that will hold and expose the vas deferens. From this moment on, the procedure is the same as that of conventional vasectomy. A ring clamp vasectomy usually offers faster healing and fewer complications, but is just as effective as a scalpel vasectomy. Immediately after the surgery is performed, the patient should rest in the doctor's office for a few minutes. The incisions will heal within a few days, leaving little or no scar. After the procedure, it is recommended to not participate in physical activity for a few days, to not bathe for 24 hours, and to avoid lifting heavy objects. Moreover, the patient will be able to resume sexual activity after a week. A vasectomy is a simple, highly effective, and safe method to avoid pregnancy. However, due to lack of information and myths about it, few men decide to perform it, because on many occasions they mistakenly think that it will affect pleasure, when in fact the pleasure will be the same. Ejaculation will be normal, and even the semen will look exactly the same, but it will no longer contain sperm. since these will disintegrate like any other cell and will be absorbed by the body.
So this is a very good video. We can make it mute and we can explain our local language. That's what I'm doing. I have too many videos to explain about all procedures in gynec and obstetrics. And I have an experience that they make a good impact and it makes our counseling easy. So audiovisuals is always the best. What is to be expected after surgery? That patient can resume sexual intercourse once pain and swelling subsides after a week, but the partner can still get pregnant until the sperm count is 0. So another method of birth control should be adopted until the patient has a follow-up sperm count test 6 to 8 weeks after the vasectomy or after 10 to 20 ejaculations. The anatomical and practical benefits of vasectomy versus tubal ligation. This we have to understand so that how easy it is we can explain to our patients. The fallopian tubes are intra-abdominal and vas deferens is under the scrotal screen. So it is very much superficial for easy surgical access. There is no risk of visceral injury. Whereas tubal ligation needs either spinal or a short general anesthesia or local plus sedation, needs an anesthetist to stand by to avoid any discomfort to patient, whereas vasectomy is done by a small nick under local anesthesia. NSV technique avoids any stitch and so minimally painful procedure, whereas tubectomy needs a stitch as layers of abdomen are opened. Surgical time is less and post-op recovery is earlier. Complications are rare and minimal, and the increasing incidence of cesarean sections, what we are facing nowadays, which increases the potential risk of adhesions and bowel injury. So there is no such risk involved as abdomen is not opened in vasectomy. Points we should know the next is social scenario, the statistics and current strategies. Why? Because it is still it is so easy surgical procedure with good results, good recovery. Still our acceptance of our patients is very poor and we should know the reasons behind so that we can rectify them. Why it is a neglected method and why it is not a preferred method of sterilization? Because social unawareness of the benefits and medico-social unawareness about family planning concepts. There are myths about vasectomy that there is difficulty for sexual act after the procedure or impotence may occur and they cannot do any heavy work. This is a common explanation given by the women that my husband may not work as before. There is a patriarchal mindset that pregnancy, delivery, breastfeeding, and childbearing, these 4 important things are borne by women. So as a part of nature, they have accepted and automatically and conveniently, next things to avoid pregnancy have purposefully shifted to her. So it is a clever rescue thought by men and a patriarchal mindset. There are misunderstandings of family planning concept. There is a convenient meaning drawn that it is a motherhood planning and hence a responsibility of a mother or a woman. In Marathi, I can say it is हे स्त्रियांचे नियोजन नाही, हे कुटुंबाचं नियोजन आहे. म्हणून फक्त स्त्रियांवर हा कुटुंब नियोजनाचा भार टाकायला नको, हे आपल्याला त्यांना समजून सांगायला लागेल. There are wrong concepts and false doctrines that vasectomy procedure or vasectomy protects against sexually transmitted diseases, including infections with HIV also. But there is a big no that it is not giving these benefits. Vasectomy will make a man impotent and reduces his sexual drive. This also is a myth and we have to give a big no for this misunderstanding. Is the couple is having any choice when we counsel? Who can do the vasectomy? Who can do the family planning procedure, whether vasectomy or tubectomy? Sadly, no. The couple has no choice. Usually it is a one-sided decision all over the globe, not only in India. So there is not tutu meme. It is usually accepted that tubectomy is the procedure what they are going to follow. There is a manly ego. So doctors counseling and wife convincing versus wife convincing is a very difficult job. More than 40% of women around the world cannot make decisions on sexual and reproductive decisions or reproductive rights. As a gynec, to my experience, when counseling the couple about vasectomy, I have tried many times, but fair enough to admit that I have not succeeded in advising the or accepting the couple or the male part to undergo vasectomy under my center. Only I'm happy that my husband had accepted and we could accept the vasectomy as a procedure for us. But usually the patient's husbands are totally on mute mode, as if non-concerned about the topic. Wives are thinking and waiting for the decision, but there is no reply, so no decision. And waiting for a while, wife usually utters, okay, do tubectomy, I will undergo the surgical procedure. So all counseling, what we do goes futile, and my tubectomy register list goes updated every time, and the vasectomy register is still empty. The global prevalence, if we see the statistics against the Indian scenario, the prevalence of sterilization here it is shown by males.
Vandana ma'am, you are muted.
Now?
Yes, ma'am, you are audible now.
So the global prevalence shows that the sterilization prevalence in India is lowest as compared to Brazil, China, USA, and the world average. And United Kingdom, it is little bit satisfactory up to 20%. Whereas the Indian scenario shows us that the tubectomy percentage is about 40% and vasectomy is less than 50,000. So comparing to this unequal statistics, men fear and avoid vasectomy, and hence the onus of family planning falls on Indian women. The news of April 2022 recently shows that India's latest health data has given the figure that nearly 38% of women have undergone tubectomy, but only 0.3% of men have undergone vasectomy. So it is a very unequal proportion. The comparison of vasectomy and tubectomy statistics in world also are showing similar figures. Tubectomy has undergone 95% plus and vasectomy only 3%. So it is not a different scenario in world and India. So there must be some common causes. The number of vasectomies conducted in India has gone down or declined from 2011 to 2015. There is a sharp decline. The prevalence and acceptance of vasectomy in India has fallen from 74.2%, considering the proportion of all sterilization in 1970 to 4.2% in 1992. Barriers in the organization structure and poor access to services may be contributing to the decrease in vasectomies. Also, between 2017 and 2018, 93.1% of sterilization procedures performed in India were on women only, and only 6.8% men underwent vasectomy. This is the report of National Health Mission. On 30th April 2022, India's latest survey, we have seen that it is only 0.3%. My local area statistics, it was my curiosity to know about what is my local district statistics. So vasectomies performed in each year in my district. I could get few figures from rural Solapur. That is 2018-19 tubectomies were in 17,000 plus, whereas 4 vasectomies. In 2019-20, there were 16,000 tubectomies compared to 11 vasectomies. In 2021, there were 8,000 tubectomies and 4 vasectomies. And 21-22, again, it is in 12,000s and 12 only. So only in 1 or 2 digit figure. And later on, I could not get the details because of the no updates from COVID side. So there are some amazing facts also in the statistics. In underdeveloped districts like Adivasi area, Nandurbar, Yavatmal, Gondia, Bhandara, the tubectomy and vasectomy proportion is 60 to 40. So whereas all other districts have 99% tubectomies, these underdeveloped districts have more percentage, 60-40. So that is a very satisfying, and we should find out what is the exact succeeding key that they have accepted vasectomy to a great percentage. The suggested protocols, excuse me for taking a gap in between because I have to move the strip which is not getting hidden, and unless I can see my slide, I can't read it. The following recommendations for counseling the patients about vasectomy may help to minimize the risk of litigation for family physicians who provide the services. We have to conduct a personal consultation with the patient for counseling, discuss the impact of vasectomy and sexual function, that is the main part where the fear lies. Explain the procedure using diagrams and videos during the office visit. Explain possible minor complications and risks, including the possibility of failure for safety of medical legal purposes. Explain the need for a post-operative semen analysis and need to use another contraceptive method for 3 months after vasectomy. Emphasize the permanence of the procedure. Have the patient read and sign the informed consent form. Provide preoperative and post-operative instructions. Answer the questions and respond to the concerns of the couple, and make telephone to the patient the day after surgery to inquire by a fair talk and get a feedback about the procedure. We have to counsel the benefits of the surgery, that vasectomy is an excellent method of permanent contraception for the couple whose family is completed and who are mature and fully informed and who will accept permanent sterility. It is also valuable in preventing bacterial epididymitis. Manhood, pleasure, and sensation are unchanged, and the woman needs no longer fear of possibility for getting an unwanted pregnancy. The complications of vasectomy. Medical complications we have to explain, though they are minor and rare, that specific complications of vasectomy include spermatic granulomas of the vas and epididymis, congestive epididymitis, and anti-sperm antibodies. Numerous studies have reported there are no deleterious effects upon the patients in general health. We have to counsel about the facts and remove fears and myths about the vasectomy so that the couple gets reassured and what they should think before vasectomy, that it is a permanent method, it is a safe and effective, it is a daycare procedure requiring hospitalization for a few hours only, not a day, only few hours. Patient should understand that sterility is not immediate. All couples, every question should be answered. They may take the form of movie or booklet or conversation with a trained counselor for that. These facilities we should make available. Use video counseling, posters, and talk in local language for the better awareness. On many occasions, we can conduct these sessions. There are many such small videos which are freely available. Just I'm showing the same video and a little bit different, that we can make it available to our patients. But as a gynecologist or as a healthcare promoter, what we can do to promote the vasectomy? We have, I have seen this website, that is World Vasectomy Day is celebrated. And this is a website of worldvasectomyday.org. They celebrate responsible Maine vasectomy here today, and virtual vasectomy is here. This is a famous area in America, the Times Square, where these are the posters and these are the celebrations happening. So they are giving much importance in making havoc for the vasectomy so that the subject keeps on in discussion. So it should be a celebration. Vasectomy clinics to make a happy dad. Celebrate vasectomy and World Vasectomy Day. This day is celebrated on every 3rd Friday of November. And this website explains that World Vasectomy Day has emerged over the past decade as a movement to encourage and educate all demographic groups, an often overlooked form of family planning. With over 1,000 participants, providers from 30+ countries, every year since 2030s, this World Vasectomy Day has brought its headquarters to different countries and inspired more than 124,000 vasectomies, 124,000 vasectomies around the world. They aim to increase the awareness of sexual health and contraceptive options, and they believe in the importance of encouraging men to share the reproductive responsibilities and become an active part of conversation. So they celebrate the response of men. And on this website, they have mentioned the vasectomy map. That way we can also make an awareness in India with the help of NGOs. So if we doctors are convinced about the need and benefits in concern with the population control of and our patients, we should dream for NSV to make a popular and preferred method. As a motto, we should keep a target that if there is a cesarean section and along with that sterilization needed, it should be, then only it should be tubal ligation. Otherwise, if interval sterilization or with previous vaginal deliveries, we should promote and counsel more about the NSV so that the unnecessary women is not forced to open her abdomen, and NSVs are quite easy and very easy for reversal also. It is my appeal to Public Awareness Committee of AMOGS and FOXI that we should involve all member societies and NGOs to celebrate and include the celebrities too. We should not wait for a government to act. We can initiate vasectomy camps monthly, similar way that 9th of every month we conduct the ANC free checkup camps under Janani Suraksha Yojana. We can plan attractive models for counseling the couple. We can have educational activities in colleges too. Celebrities can be used as testimonials or advertise purposes, which can have more mass impact effectively. We see that celebrities and Bollywood stars are shining in the commercials of gutka and pan masala. Then why can't these be used for health awareness videos on government assisted aids so that they will be not charging too much high, because gutka and pan masala are commercials and we are doing a public awareness work. But if these celebrities can do that work, they can help these social awareness programs. This is also a very good advertise that a couple is discussing कि NSV प्रक्रिया लगभग declaring that husband is declaring that NSV प्रक्रिया लगभग 20 मिनट के अंदर पूरी है. NSV पुरुषों के लिए स्थायी उपाय है. NSV प्रक्रिया में दर्द लगभग न के बराबर है. लाभार्थी 1 घंटे के बाद स्वयं चलकर अपने घर जा सकता है. NSV के बाद पुरुषों को लिंग उत्तेजना और वीर्य स्खलन पहले से ही बरकरार रहता है. Means these types can be made posters. Even poster competition, I could not see a single poster on vasectomy. So NSV पर चर्चा करने के लिए अपनी गांव की आशा या स्वास्थ्य केंद्रों पर संपर्क करें. This is from government, and this similar way we can also make from our societies and public awareness committees so that vasectomy can become a big program. To end up with my talk on vasectomy, I think that I had not covered any details about the medical legal awareness or the medical legal aspect and post-operative and consent, everything, because all these aspects can be read and we can conduct. But what is important that we should know the awareness ourselves. We are not that much serious to counsel the couple because we can do tubectomies, and vasectomy we are not trained, and we should get trained. So all gynecologists can be trained for vasectomy, or male gynecologists can do, and we can call female gynecologist if there is a concern of female gynecologist should not operate if anything happens in India. So at the concluding, I will end up my talk with this small joke that why this man is smiling. Vasectomy give yourself a permanent smile. He says, a cup of tea was being prepared for my wife as I went to have a vasectomy. When I came out in 20 minutes, she asked, still holding her cup of tea, how long will it take? Oh, I am finished. Just a second. Why this man is smiling? I will end with this talk that a cup of tea was being prepared for my wife as I went to have a vasectomy. When I came out in 20 minutes, she asked, still holding her cup of tea, how long will it take? Oh, I am finished, I replied. I would never seen my wife so thrilled at this good news till then. It's now our little joke, but that's how fast and simple vasectomy is. So World Vasectomy Day falls on the 3rd Friday of November every year. In 2023, it is on 17th November. And it is my anniversary, marriage anniversary. So I'm planning 17th November to start vasectomy free camp in my hospital. So what PSC can plan to conduct free camps for NSV and inaugurate the World Vasectomy Day for India. With this brief on awareness part more about vasectomy, I would like to thank Public Awareness Committee of FOXI as well as AMOX and all the organizers to give me this opportunity to conduct World Population Day as a mixture of celebrations and regrets and plans to have in future for population control. And by the way of vasectomy, all gynecologists should be trained and take more initiatives. Thank you once again.
Thank you, Dr. Vandana, for an excellent lecture. And we all know that vasectomy is simpler and better procedure compared to tubectomy. But we need to remember here that motivation and counseling for males is extremely difficult. And another point is, I want to stress is, please do not take tubectomy also lightly. Any complication of tubectomy, including the death of a patient, is taken very seriously by the government. And you need to do a medical legal case if there is a death on the table. Most of the problems are because of general anesthesia. So we have to be very careful, preoperative preparation, and anesthetist has to be vigilant. Don't take it very lightly. Thank you very much for giving me opportunity. My co-chairperson, if he wants to say something.
Well, Dr. Vandana, words fail to express the excellent presentation that you have made. And as you said, the nuances of vasectomy, I think the first and foremost point is we as obstetricians and gynecologists need to talk more about vasectomy and learn about it in our curriculum of the post-graduation. We first need to be trained in vasectomy, and I think we have to make it a very impactful point from the time of pregnancy. When we are talking about counseling the couple, we need to talk about vasectomy and tell them that that is a very feasible, easy, simple option for men. And of course, we have to do a private-public partnership and create a lot of awareness programs. And you very rightly brought about that. Let us start doing free vasectomy camps, not wait for the government. Let us Foxians take it up. I think that's a very good initiative. And I think we should go ahead with these type of programs. And I'm sure the Public Awareness Committee under Dr. Priyankur Roy and Dr. Monica will take this up, and let us all join our hands to start vasectomy and talk about vasectomy more in all our awareness programs. I thank AMOX and the Public Awareness Committee for giving me an opportunity to chair this session. And once again, my extreme hearty congratulations to Dr. Vandana, an excellent presentation you made.
Thank you, ma'am. Thank you.
Yeah.
Thank you.
Thank you, Dr. Bipin, for co-chairing. Thank you, sir.
Thank you, Bipin sir, and thank you, Bharti ma'am, for chairing this session. Thank you, Vandana ma'am, for an excellent presentation as always. I know how passionate you are about this topic, and that is why once I decide that we need a talk on vasectomy, I cannot think of any other name besides you.
Yes,
Thank you,
Thank you so much, ma'am.
I think only you can do the justice to the topic, the way the passion you, I think that convincingly you speak, you convince us all to do our bit, you know. We all have to put in our efforts, counsel patients. I think lots needs to be done by the government also. And you are the best person, I think. I have heard your talk, and you know, you need to keep hearing it because you're not doing it again and again. You need to learn a procedure. In fact, there is a F South in Mumbai. They train for a non-NSV to all doctors, and in between it was very compulsory for assistant professors to go and train. You know, they had made it compulsory, but later on, I don't know, they didn't perceive. So nobody went. A few batch of my assistant professor went and got trained, but few didn't. So I think it needs to be the way we do FTL camps and certification. This also needs to be done by the government.
Yes, ma'am. Let us now move forward for the next academic session, that is the panel discussion. The topic of the panel discussion is contraception and
Monica,
determination.
this is Monica. Monica, Dr.
Yes,
Shobha
ma'am.
Dudi here. I also wanted to congratulate Vandana. Excellent, excellent. I was listening to you and to Richa also. Excellent presentations, both of them. And
Thank you, ma'am.
you're right that Vandana is the correct person. There are very, very few people in our country who can speak on vasectomy, and Vandana is one of them. I think you are a national trainer, right? You were trained, I think, in the government. Were you?
Thank you,
There are
ma'am.
very
Thank you
few,
for the compliments.
very few people who are trained also. So I think it is more important to talk about it. Nobody speaks about it. So this is a good start. This year, this is a good start. So thank you for the time. Thank
you.
Thank you,
Can
madam.
I-
Thank you so much.
Hello,
Yes, sir.
hello. Can I speak? Yes,
Yes, sir.
it is a
Yes, sir.
wonderful
Rejoice, sir. Yes.
presentation by Dr. Vandana. Yes, everybody should agree to it, to me, and beautiful presentation. And speaking on vasectomy by a female gynecologist, it's hats off to you, Dr. Vandana. Nicely delivered it. Thank you so much, Vandana.
Ma'am, your passion speaks. You speak from your heart. That is what we all want to see.
Thank you so much for the opportunity.
Thank you, ma'am. Let us now move forward for the panel discussion. Can we have the slides, please? Shreyasi?
Yes, ma'am.
Yeah. Can we have the slides for the introduction? Our moderators for today are Dr. Komal Chapan,
Yes.
madam, and Dr. Ashish Kare, sir. But due to some reasons, Ashish sir is traveling and Ashwini ma'am would be taking over the presentation as a moderator. So let me introduce Dr. Komal ma'am first. Can we have the slide, please? It's the first slide here of the, yeah. Ma'am has already been introduced by Dr. Saman. She is currently the chairperson of the MTP and Family Welfare Committee of AMOX. Ma'am has been the zonal coordinator for the FOXI President 2022-23. She has been, yes, ma'am.
Introduce everybody. Let's start the panel. Yeah.
Yes, ma'am. Can we have Dr. Ashwini Kare madam's slide, please? Shreyasi?
Yes, ma'am. I'm sharing.
That'll be okay,
we'll
Monica.
also-
I think we'll start the panel. No problem.
Ma'am, then will you introduce the panelists or should I introduce them?
You can introduce the panelists and then we'll start.
Till the time that she searches for the slides, I would also like to thank all the FOXI committees who have paired in with us for this webinar. That includes the Family Welfare Committee, the Public Awareness Committee, and the MPT Committee headed by Ashish sir, Priyankur, and Richa Sharma ma'am. Thank you for FOXI for joining hands with AMOX in this initiative. Ashwini ma'am, the next slide, please. Shreyasi, the next slide, please. Yeah. The Dr. Vivek Virkar is currently the president of Solapur OBGY Society. He has worked as a lecturer in the OBGY department at DM Medical College. He's a consultant at Virkar Maternity and Nursing Home. He is also a CPS teacher at Markande Rugnalaya, and he was the treasurer at the RCOG conference. We welcome you, sir. The next slide, Shreyasi. Dr. Mini Namanputri is a consultant gynecologist. He also has the area of interest include high-risk pregnancy, infertility, and midlife management. Madam was the past president of the Navi Mumbai OBGY Society. Next slide, please. Dr. Aparna Rao is currently the president of the Aurangabad OBGY Society. She is a core fertility specialist at Aurangabad International IVF Center, practicing since the last 25 years. She's also received the Young Scientist Award at AICOG Hyderabad and Siliguri. Also received the Young Gynecologist Award at the Asia Oceania Congress at Malaysia in 1998. She has been a faculty and has done presentations in various national and international conferences. Next slide, please. Dr. Purnima Yande madam is the director of Sri Kripalu Hospital at Beed. She is a practicing gynecologist since the last 20 years with a special interest in high-risk pregnancy. She is a member of the district PCPNDT and MTP committee. We welcome you, ma'am.
Thank you.
The next slide, please. Dr. Anuradha Ganam madam is the next president of the Osmanabad OBGY Society. She is the chairperson of the Mission Pink Health Osmanabad Army branch. She has been invited as a faculty for various conferences, and she has a special interest in adolescent health. We welcome you, ma'am. Our next panelist is Dr. Ganesh Kade, sir. He's practicing gynecologist and a laparoscopic surgeon and has worked as a joint secretary AMOGS 2016 Shirdi. He is currently the president of AOGS. We welcome you, sir. Dr. Mangal Rathi, madam, is a very active public awareness committee member of AMOGS. She has been practicing in Karatwada in the district of Amravati since 1995. Her special interests include obstetric ultrasound. She has also received the late Srimati Shailja Chaudhary Award from Amravati OBGYN Society in the year 21, the Wonder Amoxian Award in the year 23, the Wonder Foxian Award in 2019. She has been invited as a faculty for many conferences and she has special interest in sports too. We welcome you, ma'am. Thank you. Yeah. Ma'am, you can start with your panel discussion now.
Thank you so much, Monica. I think lovely discussions we had today. The talks were par excellence, and now we conclude with an panel discussion. And I know we are all looking forward for a good discussion because contraception. We have spoken so much about population, family planning, and here we want to make contraception and MTP counseling in high-risk mothers, high-risk patients. How do we make it easier? So we will discuss about MTP as contraception, human rights, and women rights are human rights. And this is a survey which we did under the guidance of Pardesi sir, Dr. Sujata Darvi madam. This is the AMOGS survey. And as we have got a very huge response for the AMOGS contest, that is the poster and slogan. I think survey will hardly take a minute. Everybody should do this survey and circulate among your hospital because it is not only for the OBGYN, but all healthcare professionals. So do contribute and I'll circulate the link. The population of India, we know, is exponentially rising, surpassing the China's population, and it is actually estimated to increase till 2050, and it will almost take 100 years almost to stabilize, like 75 years from now. And when we talk about the population of India, it can be actually compared. Every state can be compared to a country. We are so much population in such a small land. I think first poster prize which got also said that 20 billion that is almost the highest population, 20% population in 2% of land. So we definitely have the area space, and that is the reason we are the most densely populated country. And this is a statement that when we talk about maternal mortality usually in these lower middle income countries is because of unsafe abortion. And one way to fight is providing them safe abortion and giving them the human sexual and reproductive rights. So the entire that we are actually very, very blessed because our country has legalized abortion. There are some countries wherein we hear a lot of things about women fighting for their rights. And that is not the scenario here. Here we have our MTP Act. And MTP Act has been even amended. And there are a lot of discussions going on about the convenience and the confusion, and everything has been sorted about it. So at least we have access to our government that the MTP is legalized, and our women also have access. So I think the awareness should increase that they should not resort to this unsafe abortion techniques. So Ashwini, you can take over from here.
Yeah. Thank you so much. First of all, the Public Awareness Committee, FOXY, and Family Welfare Committee for this wonderful initiative along with AMOGS. Thank you, Monica, for having me. So, as we all know that contraceptive rights go hand in hand with your MTP, because when contraception comes to play an important role, that is when these unsafe abortion and unintended pregnancies can definitely be avoided. So I would like to know from any one of the panelists, how effective is this MEC wheel in counseling, or how often do you come across an ANC patient in your OPD where you feel that the contraceptive counseling is really important in this case, especially when you have high risk antenatal patients? Any of the panelists can take it.
Can I answer that?
Yeah, yeah, of course, Mangal madam. Yes, yes.
Parna, very nice lecture. Now, very nice discussion headed by. I just want to tell that this chart.
Madam, we
this
cannot hear you clearly.
Okay. This wheel
There
is.
is a lot of background noise, I think.
Okay, now you can hear me?
Yes.
Yes.
Hear you now.
This wheel is a very good source for explaining to the patient, because as we all know that giving them a choice of contraception is a cafeteria approach. So this shows all the methods available, their effectiveness, but it takes time. So there should be a dedicated person, or you should give a dedicated time to the patient, because you will advise contraception, but the patient should have a firm belief in that. Otherwise, they will stop using that. If they think that this is not good, or they have many misconceptions in their minds. So we are supposed to clear them all, and like with high risk pregnancies, we are supposed to tell them pros and cons of all the methods, and what is best for them, we can suggest to them.
Madam,
Exactly.
This bill is very good, but this is very complicated. I think.
Yeah, I told I'm confusing.
Yes, so it's a simpler option should be given to a patient depending upon her need and her requirement. 2-3 options should be given to a patient.
Right. Actually, this wheel is a very compact wheel, madam, to be used by us in the OPD, because at times there are certain high risk conditions where we also get confused whether this method is to be given or not. And the patient are already a lot of Google read these days. So it becomes very easy when we counsel the patient. And once you start using it every day, like the antenatal wheel, this becomes easier to use. And as you rightly said, Aparna madam, we really need a dedicated team. We have the GREET approach for this. Madam, can we have the next slide? So here, basically, the gather approach is where you greet the patient, where you first build a rapport. You basically have to take the patient into confidence, and they have to know that you will be giving them or leading them to make a good choice. Then you ask them questions pertinent to the use of a particular contraception if they've been using it. You tell them the relevant information regarding the method of contraception and help the client to reach to a decision. Basically, these days, we do not take a decision on their behalf. We explain them about the method, and obviously we also counsel them to return to the same ongoing contraceptive method that they were being advised. So I would like to ask Purnima Yande madam, is there any special person or a special counselor that you have in your OPD where the high risk patients are counseled separately, or you would take those extra 5 minutes to counsel them?
No, I would prefer to take the extra 5 minutes to counsel them. I live in a rural area. I don't think even my staff would be so trained to talk to them or even answer their queries. I think in a private hospital, we are the best persons to talk to the patient, and they have a number of doubts, and we are the one to suggest any or clear their doubts. Our staff
True. And
cannot
the
do it.
trust that they have on you is much more than they would have with any other counselor or any other person.
And any loose comment on the part of the staff can make or break the entire discussion. We don't know how our staff, how much trained or how that much efforts in a rural area, in a private hospital. I don't think so, madam. We have to do it ourselves.
Right, right. Mangal madam, can you tell us more about this eligibility criteria where we have the MEC categories like 1, 2, 3, 4? What exactly do they mean in simple language?
There are 4 categories. Category 1 is condition have no restriction on use of a contraceptive method. There is a category 2 is indicates method use may require close follow-up. Third category is use of that method usually is not recommended unless other more appropriate methods not available. And category 4 is that conditions have an unacceptable level of risk if the method is unused.
Exactly, true. So this is how we also need to know regarding the various contraceptive methods that are available and which would be perfect for the patient and the condition. Komal madam, can we have the next slide?
So we are discussing about high risk patients. So that is the reason we have this medically eligible criteria. Our discussion is going to focus on this high risk patients.
So I would like to know from any one of you, what are the various short-acting reversible contraceptives that we can offer to these patients?
There are COCs, then POPs, then injectable DMPA, hormonal contraceptive, then vaginal rings. I don't know whether they are available, and patches. And implants, they are in
Implants
research
also
phases.
we have now.
Yeah, research phase.
So in fact, we have implants these days which are pretty easily available.
Will be long acting implants.
Yeah, they are long acting, Norplan, non-NF.
Implant training also is available. Now it is going to come in the government, and they're going to recommend implants to our patient. So slowly, I think we're moving on for LARC methods. They are the LNG, IUS, and the implants.
Exactly. So from the implants, they want to, from the Antara program, they are planning, instead of injectable DMPAs, they are going to make these implants available even in the government colleges. So these are the various intrauterine devices that we have learned, I think, from our PG days. And the next slide. I believe nobody uses them these days except removing them at hysterectomies probably.
I know, I've forgotten, lost IUCDs. So
lost IUCDs.
So basically, when we have contraception fails, and then the patient comes to for MTP, and MTP with a patient with a high risk, that's a topic. So ideally, it can be a patient who comes for an MTP and she has an underlying high risk factor, or you have a patient who has an high risk factor and you recommend MTP because we cannot continue the pregnancy. So we just had a webinar where we were moderating a cardiac panel. So such patients usually, we don't continue, advise them to continue pregnancy. And we have to choose a method, and medical method, we all know we are giving it for the early pregnancy. But there are surgical methods which are sometimes preferable. If a patient has some bleeding problem and you want everything to happen at one go, you don't want the patient to have hemorrhage. And if your tachycardia is a concern, that patient is going to have persistent tachycardia that with pain and with anxiety, and a cardiac problem may aggravate at times where you can choose a surgical method. Whereas in medical method, you will choose when you have giving position may be very difficult, or an obese patient. So this is how we will choose our patient. But my question is, before we progress to an MTP, what are the basic investigations? Because we talked about TL, I think Richa spoke so well, but what for an MTP? What basic investigations we will do, and any specific medical abortion?
Complete hemogram, madam, HIV, HbSAg, blood group if she knows it's fine, and urine routine, and RBS in the condition if she is diabetic, or then we will like to go for sugars. This basic we will do.
And any specific, if you are doing a medical abortion, any more investigations?
Medical abortion investigation.
Yes, sonography.
Sonography we will do. Without sonography we won't. That's
need an ultrasound, because we need to confirm whether it is an intrauterine pregnancy, because
ectopic pregnancy.
Scar pregnancy.
Ectopic pregnancy or scar pregnancy. So investigations, we do our hemoglobin, urine, blood group. You know, these are the basic investigation. With the sonography, they are recommended. So about contraindication. So you do the report. So if you get a hemoglobin level around say 6, what about doing an MTP for these patients?
Madam, for this patient, surgical MTP will be preferable before medical, but you give a blood transfusion or try to raise her hemoglobin level by any means possible. But if she's, it depends upon the gestation. If she's in an early pregnancy, we can wait by giving injectables, but if not, then blood transfusion and do a surgical procedure. For a patient of 6 hemoglobin, medical method is totally, I believe, is because if she bleeds, then she'll be land up in trouble.
Yeah, she may not follow up also after. We have this
another counseling which I feel has to be elaborated in medical when we are giving medical methods. What we usually see is that patient takes the pills and she has to, even if she's been told, she has to come back after 15 days to see if the abortion is complete. This doesn't happen, and then the patient lands up in a, with after 12 weeks, she comes out and then there are problems. You don't know, you want to continue the pregnancy, she wants to terminate the pregnancy, and both of the doctor and the patient.
Yes. So I think rightly choosing a patient is very important, and the follow-up which you highlighted is so important. And we know that some patients with high risk factor may not follow up, and then it will be the onus lies that the procedure may not work and they may just continue pregnancy and come later, or else they may bleed too much and it may complicate things. So we really need to be careful when we are having these medical problems, that we don't opt for medical termination and go for surgical. And definitely we take special precautions for cardiovascular patient with an intrauterine device, if there is patient with a fibroid, with a scarred uterus, patients who are on drugs. So these are the special care situations. So now we'll just begin. I think we just had little insight of this case. A 9 weeks pregnant patient comes for MTP, HB is 6 gram, and she has also hypothyroidism. So now, classically, what is the cutoff? These are just rapid fire kind of cases, not too much in detail. I just wanted to know what is actual cutoff when we take this patient for MTP.
10 grams.
Now anybody can.
10 grams, ma'am, minimum.
Yeah, everybody is going by 10 grams just for MTP.
9 grams.
More than 8. Actually, it depends on the anesthetic facilities you are having, and 8 grams is okay for me if it is a good setup.
Madam, would you go in for a medical termination for this patient or a surgical termination?
No, surgical, not 9 weeks. She is just 9 weeks.
9 weeks. So it's a surgical and
surgical.
Yeah, but around say cutoff, yes, just for doing an MTP, 8 grams is the cutoff. And for us, medical abortion patient should be around 10. For surgical, yes, you can have a cutoff little lower because you're going to control the bleeding at the same time. So anemia, as we know, is a common hematological problem. And here, if there is a thalassemia, we know that we need to confirm and then opt for the MTP. And we have all spoken that during MTP, what we have to do is maintain the proper oxygenation of this patient and don't overload fluids. This is very, very important because complications occur because of it. And certain bleeding tendencies if the patient has, we need to avoid this NSAIDs and oxytocin. So coming to the thyroid, any special care for a thyroid, because she's also had a hypothyroid. So Dr. Mangala Rathi, if patient has an uncontrolled thyroid, whether hypo or hyper, how do you actually assess this patient for MTP, for a surgical MTP? You can unmute yourself.
First, correct her thyroid level with proper medication with physician and endocrinologist, and then we will go ahead.
Yes. So underlying problem should be controlled, because if there is an hyperthyroidism, thyroid storm is very common. So we need to check her levels. And thyroid hormones in pregnancy is going to change because of the physiological changes also. So we really need a proper report, a pregnancy report, not a pre-pregnancy report. She's saying that she's a hyperthyroid or hypothyroid. You repeat a report when she's pregnant. And then you can just discuss with your anesthetist and do. Now coming to the contraception for this patient, it is again a trick, and Ashwini is going to take for the contraception. Rapid fire now.
Yeah, any one of you can tell me what would be the most suitable contraception for these patients?
For thyroid,
With anemia and thyroid.
Combined OC pills can be given, madam. These all come in a medical MEC category. So you can.
So the best part is all contraception would be safe in these patients, so we have a wider choice. Yeah.
Yes.
And basically, I would also like to ask any one of you that when you give medical abortion to these patients, would you also give any contraception along with your first dose of mifepristone? Would that be advised? Does anybody practice that?
No. Patient
In fact, in government programs, they say that when you give them the first dose of mifepristone, you can also actually give them injectable DMPA on that day itself. It doesn't hamper with the process of abortion, and it's a good contraception also.
But in case the patient doesn't comes back and she continues and then later on she can blame us.
No,
for
madam, that is when you give her only mifepristone. Meso is still with you. They have to come back to take the misoprostol after
Okay,
40
we are
days.
not giving them.
No, we don't trust them
But
blindly.
madam, medroxyprogesterone causes intermittent bleeding. So how will you differentiate whether it becomes a abortion?
It
Even after
doesn't cause
15
intermittent bleeding immediately, madam. That happens after 3 to 6 weeks. So the abortion is complete, which you confirm after 7 days after the ultrasound. And plus the contraception is also ensured in these cases.
These are the recommendations, but in practice, I think we will confirm and then only we will give, ma'am.
And also,
No, it is only after the consent and counseling.
Yes,
Definitely.
And also start oral contraceptive pill. We can start when you're giving your second dose or when the patient comes for a follow-up to confirm. And start with oral contraceptive pills also for that patient from that cycle. So you need not wait for her to get her menses, and then come for follow-up.
Exactly.
Yes,
Patient follow up. If you tell them you come after the menses and see me, nobody is going to come back. So we need to start contraception as early and address it. So then coming to the next case, she's a 35-year-old, Gravida 3, Para 2, living 2, 8 weeks. She's come for MTP. She has a previous to LSCS, which was done in view of preeclampsia 6 years ago. And she's a known case of hypertension also, taking Amlo 5 mg OD. She's diabetic also on oral hypoglycemic drug. Her BMI is 28. Now, how will you proceed? Dr. Yende, madam, you can start and
proceed with the basic investigations, madam. Hemoglobin, and since she is diabetic, her sugar levels, since she is hypertensive, I would also suggest for a LFT, KFT levels and a physician opinion, ECG if required. Because nowadays medico-legally problems, if she's such a high-risk patient, it's, then all physician opinion for a medical termination can also be taken. And then we can proceed. I would prefer a surgical MTP for this, but before proceeding for surgery, then priming of cervix is important.
Yes. So you have rightly said, and in fact, I think certain state, like even I was also surprised, the Tamil Nadu government program in their hospitals, and they are even in the private practice, they are doing compulsory ECG for all patients, all pregnant patients, they are doing ECG, which is not come here. And they see when there are high-risk patients like for hypertensive or diabetes. I'm not doing myself. I was surprised when they said that there is almost a kind of a guidelines, passing guidelines that they are all doing compulsory ECG. So such patients, when you get a high-risk patient, you can definitely consider doing ECG, which rightly has been said. And here we need to control the blood pressure. Here the morning dose of antihypertensives to be given. Actually, I can ask somebody, Dr. Who is there? Dr. Anuradha, yeah, you can tell me, how do you go about when you're taking her for surgical abortion? What care you take about the hypertensive aspect of this patient?
She should take the morning dose of her pill, ma'am, in hypertension. If she is diabetic also, so she is also, we will do her sugars, and accordingly we will adjust the doses of insulin if required. She has to be nil by mouth for at least 6 hours.
And what about the drugs? Certain drugs which will, because she's hypertensive, we need to be really that ergot drugs. We will definitely.
Methargine we are going to avoid, ma'am. Methargine we are not going to give to a patient. And oxytocin, misoprost we can use.
Yes. And Dr. Aparna, what about the diabetes? She's taking already oral hypoglycemic agents. So we have given her the morning dose of hypertensive. What about the diabetic medication? Do we continue?
She can take, no, she can take the anti-diabetic in the night. Then we have to do a fasting sugar levels, and accordingly, I missed out the weeks of gestation, ma'am. Can you tell me what are the
8 weeks?
Yeah,
8 weeks.
Okay. Then during the procedure, it's better if you shift to insulin. If required, you can give a titrating drip of D5 with 8-unit actrapid, human actrapid insulin to control the sugar levels. And then after the procedure, when she is settled, she can again shift to oral hypoglycemic agents.
Yes, yes, perfect, perfect. Now coming to Ashwini, the contraception.
I would like to know that what kind of contraception would we advise her, looking at that she is a G3, P2 with already 2 comorbidities.
It's better
So
if
what-
husband undergoes vasectomy. Husband should go undergo vasectomy.
COCs and
They
POPs
should
are
be this
again
easy
casual.
that me telling them and they are undergoing the operative.
But
I know.
This will be the best time to
I
tell the
happen-
husband to get operated.
We will get Vandana madam to convince her online.
Exactly. In case the husband is not ready to do so, I think doing a
Actually,
permanent
no.
sterilization for this patient would be much better because she's already completed a family also and she's already at high risk of hypertension, diabetes. Any other method other than permanent sterilization that the patient can be put on?
IUCDs will be better more than drugs.
Sorry?
IUCD is better.
Yeah,
Hormonal
exactly.
drugs
Because we are
prefer
anyways
IUCD
taking
more
her
than
up for a surgical procedure. So it will also be a painless insertion for her.
UCD, LNG-IUs would be very good for
LNG-IUD is the best
she
thing.
has hypertension, she has diabetes, and she is obese. So
Yes.
with that, LNG-IUS will give her a long-term benefit. So that will be one of the which will take care of the endometrial factor also. So this is a
Exactly.
Yes. So coming to the hypertensive, we know that we will definitely avoid OC pills, combined hormone pills as a first choice, but we can definitely give progesterone pill. I think we discussed diabetic. I
Any
don't know.
estrogen would be very risky in these patients of hypertension because they may at any time land up in thrombosis or embolism.
We have POP only pills also. PO.
Yes, exactly.
Available.
That is one more option that we can give them.
Yes.
To the diabetes, the contraception for diabetic, because she's a diabetic also. So which would be your first choice?
POPs, ma'am. Or
No.
Is
My
IUCD
first IUCD is better.
Exactly.
Exactly.
IUCD is better. We can't risk the missing out pills and then getting her pregnant again. It's very risky to do NTPs again and again.
Yes. And I think
Exactly.
IUCD are a contraindication for diabetes. So we never say that IUCD is a contraindication. We can safely give to a well-controlled, good diabetic patient. And by all guidelines, it is even a MEC1 criteria, eligibility. So we should recommend IUCD for this patient, specifically for this patient. Because it is a LARC method. A LARC method is always better than putting them on a short-acting method. Okay. Obesity also we have discussed. Yes, tubal ligation, can we do? I think somebody had said that we'll go ahead for tubal ligation. Is it safe? Any
Yes,
specific,
madam.
any specific investigation that can be done? Tubal ligation, nothing. We can safely go ahead.
Good
And sugar
antibiotic coverage.
With blood
Good
pressure.
antibiotic.
They're all okay doing tubal ligation.
Yes,
Prefer
madam.
to tubal ligation, madam. Actually.
Yes. Should actually this patient should be, she's a previous to LSCA, she should be counseled for tubal ligation. So don't hesitate if you document everything properly, as the previous talk said,
Take the fitness and all.
you can definitely go ahead.
If she is fit for MTP, she is fit for tubal ligation also.
Yes.
Yeah.
Exactly. Right.
Not
So with a
hesitate. There are some people who are okay doing MTP, but they really avoid doing tubal ligation in high risk patients.
Then
So I
she
think-
should go and get operated at a tertiary center.
Yes, tertiary center tubal ligation, best. I think we are very expert now. Coming to the-
So even in these obese patients where the BMI is less than 30, all kinds of contraception can be given easily. So if this specific patient is to be talked about, a permanent sterilization would be best for her. And in case she is not ready for that, we can always go in for an intrauterine device.
So I think IUCD scores better in every patient, till
Every
now.
patient.
Every
And
patient.
of that, the LNG-IUS is the best these days.
Yes, it is. And now we are discussing this about a patient who is having a heart disease. So we're not going to detail of her heart disease, but she's having a heart disease and she's come with a pulmonary arterial hypertension, VSD. So is this patient a choice for heart disease, or which cardiac conditions will you actually advise MTP?
Pulmonary hypertension, coarctation of aorta, severe mitral stenosis, severe systematic aortic stenosis, we can advise in this situation MTP.
Yes, so we are going to advise MTP. So here we are advising MTP. She coming for MTP is a different issue. So we are cardiac condition. So what will be the right time to do this MTP? She's come to you early, maybe she comes at around 7 weeks. So will you investigate and what would be your actual timing? You want to do it as early as possible, wait and do?
So it is as early as possible, but her clinical status has to be stabilized first. Now when you about this specific patient, she was having difficulty in breathing. She was having epistaxis. You have to have a clinician's advice about it. The cardiologist. Once she's stable, we can do MTP as soon as possible then.
Yes. So these are the contraindications. WHO class 4, pulmonary arterial hypertension of any cause come under this category. So when we get a patient with severe condition, we definitely advise MTP, and doing as early as possible will be beneficial because we know the hemodynamic changes of pregnancy are going to progress. And in the second trimester, it is going to become more problematic for the patient. So doing it as early after stabilizing is the best choice. And so this patient actually came for MTP, but she didn't turn back, and now she came for a second time. So it was a dilemma. So now when we have told her, but she said, no, I want to pregnancy, went to some village, and she came back again in second trimester. So now she's almost around 19 weeks. So can we do MTP here at the second trimester MTP in this patient, or delivery is okay?
Madam, now she should be considered, and there will be risk is more of doing MTP at this stage of 20 weeks.
We can do hysterotomy here.
Yeah.
Madam, she's primary gravida. How can we advise?
Oh, I'm so sorry. I didn't get
we have to counsel and we have to explain her all the risks, and now she has to continue, and as we have to take care of her by a multidisciplinary approach with a cardiologist and the intensivist and every care. I think doing MTP at this stage is also involves a lot of risk to her life.
So this was actually a real case. So she didn't come back, and then she came again at 18 weeks, and we get stressed, when patient does like this. And now again, she's coming because MTP was advised, but she didn't do. She comes back and now she says what to do. And she said somebody had expired in Gaon and she went to village and she came. So definitely we require a cardiological opinion, in this patient, because if her general condition, or if there is lot of, shunting, the degree of shunting right to left is higher, or the pulmonary perfusion is decreased, and she's compromised, still we can do termination. That's what was advised to us, that yes, you can go ahead, because as she is going to progress, the pregnancy is going to progress, her condition will become even more worse. That was advised to us, and then we went ahead the second trimester MTP for this patient. So by explaining the risk and everything, and ultimately we did an MTP for the patient. And what extra care now, if you have a patient of MTP, of cardiac disease, for an MTP or a surgical MTP. So yes, Dr. Mangala Rathi or Dr. Yende madam. So what care you will take? What you will tell your anesthetist or your assistant? Extra care about drugs, about fluids?
Fluids have to be restricted in this case. Very minimal fluids have to be given. And in anesthetic, even if you have the habit of using prostaglandins before for priming of cervix or even after, Mithergin and prostaglandins have to be strictly avoided. And post-op care has to be very, very thorough. And we have to get a cardiologist involved, and antibiotic prophylaxis. SAB prophylaxis is also very important for this patient.
Yes, this is very important to give empirical good antibiotic coverage, and this all precautions you can take, and you can really do MTP in cardiac patients safer. And this is for the patients who are on anticoagulant or who have prosthetic valves. We really need to stop if they are on warfarin or any other anticoagulant, it needs to be stopped before surgery at least 5 days in advance. And then you can take this patient for an operative delivery. An operative is better, even if these patients come early. You don't give them medical line of management. Surgical management will be definitely preferable in these patients. So coming to the contraceptive part, Dr. Ashwini, now anybody can take. Yes.
Intrauterine device.
Everybody wants intrauterine device. Now IUCD has become the favorite, I think, for
It's
everybody.
the hot selling. Basically, initially in our postgraduate days, we were taught that in these heart disease patients, you should not insert a intrauterine device, it may cause infection. But then it is very much safer now. And if this patient is already undergoing a surgical evacuation, maybe, and if she's already there in your hospital, so it's much easier to insert it.
Madam,
if
one
these-
point I have to say before surgical intervention, when you're talking, if the patient is on anti-thrombolytic agents, the PT-INR and coagulation profile is also must for such patients.
Yes,
because
exactly.
after MTP, she bleeds, then she bleeds very badly.
Yes, we
True.
need to do the detailed coagulation profile for.
Yes, and
we have
these
to wait
patients
unless and until her parameters are normal.
like any other MTP patients who go back home, these patients may have to stay a little longer, even for 5 days also post-op monitoring.
So this is again the valvular heart disease. I think the MEC one is showing again IUCD.
Yeah,
every.
exactly. If you have pulmonary artery hypertension, the implants and DMPA can be used pretty safely. And in majority of the cases, all these intrauterine devices are safe. Anything that has estrogen is a complete no in all these cases.
Yes. So I think we are very clear about
the combined hormonal pills.
Yeah, and again, you see IUCD is higher here with patients having venous thromboembolism. So I think we need counselor so that they accept IUCD. That's okay. And IUCD, LNG, IUS is almost the choice everywhere. So coming to the asthmatic, any special precautions you will take? A 7 weeks come for an MTP who is using a pump. So any extra care while doing MTP for an asthmatic, Dr. Aparna?
Hello.
Yeah, hello.
We avoid misoprostol in these patients because it can cause bronchospasm. Hello.
Misoprostol? No.
No.
We can use.
Misoprostol is avoided.
Misoprostol we can use.
It's written in misoprostol
Not,
that avoiding
not
bronchial
contraindicated. No, misoprostol for vaginity can be given.
Not
Sublingually can be.
contraindicated.
It's not contraindicated.
Misoprostol is not.
Prostaglandin
Prostaglandin
cannot be given.
Prostaglandin.
Which prostaglandin? F2 alpha and this is prostaglandin E2. So prostaglandins are like one can be given and one cannot be given. Is it like that?
Yes, it's local action.
Yes.
Yes, I think
Misoprostol doesn't cause bronchoconstriction.
Take part in panel, yeah. We have Dr. Sangle, so you can take part in the panel. So definitely we need to avoid giving PG alpha. That is not recommended, but misoprostol you can give to these patients. And we really need to be very careful. There is no extra care or something for asthmatic per se, but only these precautions we need to remember when we have a patient with asthma. And nebulization. So there is no, okay. Now we have some special situation. I think Ashwini, you can take.
Yeah, as far as liver diseases and contraception is concerned, Sanjay sir, could you enlighten us which contraception would be safe in acute hepatitis or in chronic hepatitis?
Can I tell?
Yeah, yes.
IUCD.
You have to unmute.
Hello.
Yeah.
Yes.
Only pills, intrauterine device and barrier methods are most important.
Exactly. So basically, all the estrogen containing are avoided whenever you have acute hepatitis or there is a flare of these acute conditions or any liver malignancy, because all the estrogen gets metabolized in the liver. So they are to be avoided only in these two conditions. Otherwise, you can use all kind of contraception in these chronic cases or when you have a carrier of hepatitis. Can we have the next slide? So even in mild cirrhosis, all kinds of contraception can be used. And whenever you have benign focal hyperplasias or hepatocellular carcinomas, the copper IUCDs work really well.
Ashwini madam, can I ask one question? All these, hello?
Yes, yes.
All these MECs which we are saying, it is all for females. No talk about barrier contraceptive or condom use, which will be best in all these cases where the female
That
has
is
some
so
chronic
there, madam.
disease.
That goes without saying. But
No,
basically,
no,
since the usage is less, we are talking more about female contraception.
No, it is not that way. When we talk about the contraceptive efficacy, barrier and all, they score very low on the chart. So we are talking about the most effective contraception. So what are the most
And
effective?
plus, these are all the high risk cases which we are talking about. These are not the regular
For
patients.
IUCD, contraceptive pills, implants, injectables. You know, these are the, when they are most used in the most effective way, their failure rates are very, very less, 99.9. Success rates and the failure rate is very, very low. So that is the reason we are talking about these. When we are using a barrier method or a diaphragm or a female or a male condom, we know they are not going to be effective. We may have a patient come back with failure. So we're talking only about MEC criteria for all these contraceptive methods. For condom, MEC 1 is for all. So there is no MEC criteria. We are going to talk about barrier because they fit into the most suited for all pathologies. Okay.
Thank you, madam. Thank you.
So that is the reason. Now coming to epilepsy. So we also sometimes have an epileptic patient coming for an abortion. So anybody managed patients, how to go? I have an epileptic waiting to for an abortion, MTP. So can you just tell what care do we take during an MTP in epileptic?
Drug interactions.
Anuradha, yes.
Drug interactions are more, ma'am. I think mifepristone dose may be increased in the patient who are already on anti-epileptic drug. And if seizure occurs during the abortion, I think for these patients, we will prefer more surgical abortion because stress may increase they may have more epileptic attacks when we are following them for 15 days. So we will go for preferably a surgical abortion. And if seizure occurs during the abortion, then appropriate measure, because surgically if we are doing, then we will have an anesthetist with our hand. And post-abortion contraception is, again, there are a lot of drug interactions with combined OC pills. We won't advocate to a patient who are on epilepsy. I think the best will be again a copper IUDs or a hormonal IUDs, Mirena and all, because there will be a lot of drug interactions.
Exactly. So we have to tell them that even if they are taking the POPs, they have to take it with their anti-epileptics. That goes without saying, because if it is well controlled with even one epileptic drug, that has to be continued definitely.
Yes. So epileptic patients and even in migraine, we can see that copper IUCD is scoring a higher because or a progesterone only pill. If taken effectively, this contraception is going to give us the best effect in all these. And estrogen containing we need to avoid. So we are talking about all the high risk problems. I think most of it we really need to avoid the estrogen part, except for the anemia. I think all the high risk patients we really don't recommend taking an estrogen. Now coming to the immunological problems.
So again, in all these cases, the intrauterine devices or the progesterone only pills score much better than all your other contraceptive methods.
Yes. So we sometimes have these patients like with SLE coming and getting pregnant, and then they want contraceptives. So you can definitely suggest them our IUCDs or implants. And there are certain, we spoke about the gynecological problems also. So these are the gynecological conditions. Sometimes we have high-risk patients coming not pregnant, but sometimes they come with gynaec-related problems. And they are having a gynaec problem and plus they come to seek contraception. So we need to give them such a method which will take care of their gynec problem as well as contraception. So I think anybody can comment, Dr. Rathi, Dr. Raul, for endometriosis, for tumors.
For any kind of heavy menstrual bleeding, what could be the best in them?
LNG ultrasounds, intrauterine contraceptive device are best. Then DNC is also good for endometriosis. Hello.
Okay.
And
Yeah, yeah.
progesterone only fits, because we need to give them progesterone. Like any device which is giving them progesterone is good.
Yes,
Be it
Exactly.
injectable,
Madam, when
be it
you
IV.
use these LNG IUS in these patients with heavy menstrual bleeding, would you want to do any pipel biopsy before you want to
Yes,
insert the LNG
definitely
IUS?
definitely for atypical changes, then only insert, because it will be there in for 5 years then.
Exactly. And
yeah, Ashwini, you continue.
yes, yes. What would be your follow-up after inserting this LNG IUS if the patient has atypical hyperplasia?
Then we need to remove that IUCD.
Okay, so basically now RCOG says that you can continue with this LNG even if there is atypical hyperplasia.
But then we need to follow them up with ultrasound.
Exactly.
Regular
So
ultrasound.
follow-up is very important. You have to do annual pipel biopsies with these patients. And if the atypia is persistent even with this LNG IUS, then these are the candidates for permanent methods like hysterectomy.
Yes.
Okay. So when these come to us, it is always better that we can treat them medically, or instead of directly taking up them for hysterectomy, this can be, but then annual and a thorough follow-up is definitely needed.
Yes, and and it is not necessary that patients are having already some gynec problems and they may conceive. So a patient may be with endometriosis, she may be having irregular period or ovarian tumor or a heavy menstrual bleeding. Can land up for pregnancy. So we need to address contraception even in these patients, not to think that she's having a problem, she may not conceive. So it may be an unwanted pregnancy at that age. So definitely counseling contraception is very important, and a follow-up, as Ashwini pointed out. But my question is that now we know that IUCD is very much in, and LNG IUS also scores very good in this high-risk patient. So my just general question is, how receptive are your patients? Like, do they accept IUCD, particularly the LNG IUS for contraception? This is what is coming into my mind. We are recommending, but what is the acceptance of the patient? So we can start with Rahul. Dr. Yende, madam, Dr. Aparna Raul.
I think except for the cost, it is acceptable. When you have to talk for the risk-benefit ratio, copper tea is freely available. Otherwise, also it is cheap. But these Mirena and they're all expensive. Except for the cost.
Now you have even low cost LNG IUS, madam.
Yes,
Initially,
yes.
when there was only Mirena in the market, it was really very costly.
5,000. Now,
so generally,
Aparna, madam, how important is counseling in these patients of LNG IUS? Because they still keep on spotting. It is not that they achieve amenorrhea immediately.
They keep on coming to you, and then you have to explain it, and they are worried a lot. Then they are usually worried about whether the property has been displaced or it is not there. So we can confirm it by an ultrasound, and then it can show that it is in place. Counsel a patient according to her
bleeding will be there.
According to her level of understanding, you have to explain.
True.
I think
Irregular
counseling
bleeding will be there, madam, for 6 months. I think we have to counsel the patient for that. But they have an excellent contraceptive efficacy. That is very important that we should counsel the patient. Even for gynecological disorders, when we are inserting for a DUB and all, that time also it is very important that you should counsel. There will be irregular bleeding, spotting, and to be amenorrheic, it will take some time, maybe 1.5 years. Then after that, there will be less bleeding and there will be longer periods of amenorrhea.
Okay,
otherwise, they will go on coming to you every time that they will have irregular bleeding and spotting. They won't be happy with that.
Yes, patients
So we
are
have to
not
be very clear in our counseling, saying that 3 to 6 cycles is the time that you will require, because your ovaries are still functioning, even though the endometrium may take time to shrink. Because they feel that if you have inserted some magical intrauterine device which is costlier than the others, it should immediately work. So that doesn't happen.
True.
Yes.
Yes, yes, very true.
Now coming to something which is very little, we spoke about IUCD, we all agreed LNG and IUCD is the best. But when we have a distorted cavity with a uterine fibroids or anatomical problems or a past history of PID, how do we go about giving contraceptive choice? So how do we choose the best for this patient? So what will be your options?
My option will be progesterone only pills.
Yeah.
Past
Yes.
history of PID is no
My
contraindication.
my option will be DMPA. I'm like very good follower of DMPA because it was my thesis topic. So I
Wow.
always prefer
Wow.
DMPA in these patients. Like I was a part of Upjohn study in India when it was launched. So I have a lot
Very
of
nice.
experience. Also, I have around 50 patients on DMPA. It's a very
Oh,
good choice, and if you, with good counseling, it is a very good contraceptive method because the follow-up is less with the patients.
the patients
And you know,
prefer
with the
taking
COVID coming up, madam, the best part was that the patients even self-injected at home at times
Yeah,
when they
yeah,
did the
yeah.
follow-up with this Antara. So they feel good about it, that they don't have to visit the doctor every time.
I have a
And what
diabetic
about
patient. I have
Huh?
a diabetic patient who is taking right now. She has taken at least this was her 26th dose of DMPA, and she is getting regular cycles. I don't know how.
with DMPA.
With DMPA,
Wonderful.
this was her 26th dose, and she is getting regular periods.
But
Now
she's
she is
getting
43.
Great, great.
that is important.
Very nice.
Yeah. And she's getting contraceptive benefit too. So I think when we talk about distorted cavity or anything here, DMPA, the injectables and the implants, which are coming in a new way. In fact, on the World Population Day in Mumbai, the Mumbai Obstetrics and Gynec Society, we had implant training, you know. We got trained for inserting the implants, and I think it is going on very widely everywhere. And sooner the implants will be accepted and it will be available widely, but you just require to train it because it teaches a special technique to insert it and also the removal because patients come for removal also. So that is very, very important. Training need to be done.
To work, they only train to insert. I mean, the training was not widely done for removal, and that is how it went into. But now it's coming back again.
Again, so now they're training both insertion and remove, and
Removal
slowly
also.
everybody will get trained, and then we will know the importance, and patient may accept it also early, like how the Western people are accepting implants more than even the IUS, LNG IUS. So now coming to the last situation, I think we are in the infection. That is, we spoke about infection, but now comes the HIV infections. And is contraception very necessary for HIV patients? What do you
Yes.
think?
Yes.
Yes.
It is
Yes.
very
Yes.
important.
It is even more necessary for the patients. We really don't want this patient to have unwanted pregnancy.
Yes.
So what about the choice now? Contraception? Well, Rati,
Can give good
All
results.
contraception.
all contraception. CD4 count before giving contraception.
CD.
That's some disturbance. Yeah. Is the CD4 count going to give us any insight into which contraception?
If the count is very less, then initiation should be stopped because it may flourish the infection. Otherwise, we can give. If the CD4 count is good, more than 200, then we can initiate. We can insert the implants, copper Ts or a Mirena, whatever.
Yeah. So
But the
CD4
barrier should be advised to the patients who are on HIV to prevent the spread of infection along with this good method of contraception.
This patient will require a dual contraception.
Dual contraception, yes.
Yes. We'll have to give barrier along with everything because she is HIV positive, and CD4 counts, if they are well controlled and about 200, definitely you can even give the copper T or the LNG IUS. But if they are lower, definitely avoid insertion, anything. About the cancers, the cervical cancer, endometrial cancer, ovarian cancer. Ashwini, you can take.
Yeah, so I would like to know from any one of you that would you advise contraception in these cases of cancer?
Yeah.
Of course. If needed.
Yes, we have
Depending
to.
upon the
So
age of the patient, yes, CIN1, CIN2, CIN3, they are the best candidates.
right. So what would be the ideal contraception in endometrial cancers?
Endometrial, I think, Mirena and
DMPA will be
POPs.
Yes, for all early carcinomas, all these progesterone implants, they work as a treatment of cancer also. So they will be very good and safe. And as far as ovarian cancers are concerned, we can use all kinds of contraception.
Yes.
Yeah.
Ovarian cancer, you can actually use all kind. And in GTN also. What about your opinion on
Yes,
GTN? Yes.
Yes, ma'am.
Yeah, doctor. I think
Aparna, madam, you would like to take this, the gestational trophoblastic diseases? Garad, madam, you want to take it?
We can use the combined OCPs. They are very safe. I think IUCDs we will avoid in GT, in gestational trophoblastic disease. These are the best to be given with the combined OCPs.
Yes, I think this is only where we can actually go for the combined.
Because perforation will be, chances will be more. So you want to avoid the copper Ts and Mirenas.
Yes. Very well. Where we can use a combined hormonal pill or a progesterone only pills or even will be better. And now coming to the breast cancer, I think our incidence is rising. We know these patients are there who are already taking treatment. Also, there are a lot of case scenarios. And how would you go about advising contraception to this patient?
Copper IUD is best.
Best. OCPs is a category 4 in the patient who has a current breast cancer. But if there is a family history and all, you can still advocate. If you have a family history and a benign breast masses, combined OCPs can be advocated. But patients who has a breast cancer is a category 4. We are not supposed to advise. In that case, we will advise the IUDs and Mirenas.
Yes, I think IUD will be safer here because it is definitely non-hormonal and we don't want patients who are already taking any drug or any problem with estrogen containing pills. So copper IUCD is best, but rightly said, if patient is having a benign breast disease or if a patient is not having any bigger problem, you can actually give her all contraceptives and you can keep the patient under follow-up. But if there is a family history also, all methods can be given. But if patient is actually having the disease, then you are worried and you need to give only as per the eligibility criteria. So this is how it is. And because, in cases of inflammatory bowel disease, IBD, and these are also very common conditions, or cholestasis. Can you give OC pills in this patient?
Category 3. Gallbladder disease, COCs are not advocated.
Yes, we want your opinion also, your experience. Is the connection there? Hello?
Yes, ma'am.
Yes, madam.
Yes, ma'am.
No, I'm not able to see anybody. So I was asking. Okay. So I think we are all okay with giving IUCD. We have spoken. So I think we can just wind up because this is the contraceptive chart for the postpartum patient. And in postpartum patient also, initially we promote the exclusive breastfeeding or the lactational amenorrhea method. And if patient is not exclusively breastfeeding, we can introduce POPs or implant. And if patient is breastfeeding, then after 6 weeks, we can give the DMP. I think Dr. Aparna Rao said that DMPA, she has done so many, and even I am also now very impressed and convinced. So DMPA can be given to this patient along with your POPs and LNG IUS. Copper T can be copper IUCD can be inserted immediately postpartum. That is a postpartum PP IUCD. What we usually do it can be done post-placental or even trans-abdominal during cesarean section. So copper IUCD definitely becomes very good. Only I think the medical eligibility criteria for copper T is when the patient is having prolonged leaking. PPROM patients you should not put as a post-placental or PP IUCD. So apart from that, all patients you can definitely put IUCD, and if the patients having any history of Wilson's disease, those are the contraindications. Rest, you can definitely give copper IUCD, and definitely the combined oral contraceptive pills you will avoid because of the breastfeeding effect, and progesterone only pills. We have good progesterone pills with LNG, IUS, and implants can be given. So postpartum contraception, it is actually not till 6 weeks, but it is till 1 year. There is the extended postpartum contraception. And I think that 1 year is very important because most of the unwanted pregnancies happen during this period. And if you don't target it, we land up into MTPs, and the high-risk patients having MTPs again becomes more high risk. So we really need to target this postpartum. And I think Ashwini can sum up this.
How frequently in your private practice, madam, do you insert this copper T? I mean, how is the acceptance in private practice? I have inserted a lot in government colleges, but how do you think is the acceptance in private practice?
Very well, madam. Very well. Especially after an MTP, first trimester MTP.
No, I'm asking postpartum.
Postpartum private.
Cesarean.
No, private patients, no, ma'am.
No.
I have never started.
In
I think
government,
that-
I think it might be on paper that you're counseling and you're taking a consent, but it actually doesn't happen that way. Because there are a lot of patients who come up to us and then we remove those properties because they are not ready for it. This is our scenario. I cannot talk about
We are
others.
removing lot of postpartum IUCDs. They directly come from the civil hospital to us to remove the property. They are not happy with it.
When we ask whether you have given consent for it, they say no. Whether you have been counseled for it,
They have just inserted.
They have just inserted.
Acceptance is still not there. People are not like, it's a good method, but
yes.
I think with a lot of counseling and hammering, which starts early on in the antenatal period, it may gain a little acceptance. What happens is that when the patient comes in for a cesarean, when you're taking that consent in that hurry, that resident also says, no, we want to insert this also, sign here, sign there. So maybe that is one reason that the acceptance is still not there. But if we tell them the benefits properly a little earlier, it may gain acceptance soon. Summing up to the... Yes, madam?
LACS or a cesarean, I make it a point to counsel that patient in the antenatal period only. And if the patient is having a previous cesareans, maybe 1 or 2. So depending upon her family, child and everything, even for 2, sometimes they are willing for tubal ligation. I say, no, put a IUCD. It is so simple. Why should we tell? Because if she's willing, it's not demotivating. It is choosing a contraceptive method. So we need to counsel them antenatally only. Ashwini has rightly pointed during LACS to 100%. But during delivery, sometimes they change their mind because then they have the control. They will say, "Abhi mat dalo." You know, I have seen so many patients going back, reverting back the normal delivery cases. So those needs recounseling. But once they are on the OT table, then the consent is already taken. You know, so So that is how it goes. So I think
and as post-abortion contraception is concerned, if in the first trimester, all kind of contraception is very safe. And I think post-abortion is also one section where we should not miss the opportunity of actually counseling them and telling them that coming in for a repeat abortion is much unsafe than going in for some kind of a contraception.
Yes.
I think we had a wonderful panel where we covered everything and all kind of high-risk cases, all possible situations.
Yeah, right from the anemia till thyroid and scissors and everything. So I think, yes, it was good. I think everybody.
Wonderful moderators.
Thank you.
Jawan madam and Ashwini Kare madam, wonderful moderators.
Thank you so much. So I just end a quote by J.K. Rowling. our choices show that we truly are far more than our abilities. And so women should have the choice to choose, plan their family and access to termination of pregnancy. So with that, we end our panel. Thank you so much. And just a sincere appeal, please do vote. Tell everybody to vote from your society. Just pass on the message that they need to vote on 1st of August. It will take a minute. Please vote for me. I am your candidate from the West Zone for the Foxy Vice President. From AMOGS and from Foxy. So please do vote.
To all the very best.
All the best.
I'm sure
You're
you
going to
take
win.
Foxy
You're going to
all
win,
the
ma'am.
very best.
Thank you. Thank you. Please pass on the message. Thank Obliged. Stop sharing.
Thank you, ma'am, and wishing you all the best for all your future endeavors and this election. I would officially want to propose the vote of thanks. I would also thank Pai sir, Pardesi sir, Sujata madam and Madhuri madam for consenting to be the chief guest and the guest of honor, and for their constant encouragement and saying yes to all our programs. Our judges, Dr. Ajay Mani sir, Dr. Kiran Purpoti sir, Dr. Shobha Gudi madam and Dr. Lakshmi ma'am for being the judges for our poster and slogan competition. I must say it was a very tough task for them. Our chairpersons, Dipin sir, Priyankur, Bharti madam, and Dr. Bijoy Nayak sir for chairing the sessions. Our speakers, Richa Sharma madam and Vandana ma'am. Our moderators, Komal ma'am and Ashwini Kare madam. Our panelists, Purnima ma'am, Aparna ma'am, Dr. Ganesh sir, Dr. Vivek Virkar sir. He was in a medical emergency, so he couldn't join. Thank Purnima ma'am, thank you so much. She always says yes for all my calls. I have been constantly troubling her since last 1 month for all the webinars. Thank you to ClearNet for providing us with an academic platform. Wishing you a very good evening and good night, everybody. Thank you so much.
Thank you.
Thank you, Anuradha ma'am. I forgot your name. Sorry.
Nice to see Anuradha. Very nice. Great. I think we had lovely discussion. Thank you, Purnima madam. Vandana Gandhi madam's talk was mind-blowing. Thank you. Thank you, Dr. Mangal Rathi. Monica, bye. Thank you, ClearNet team.
Thank you so much. Thank you so much, everyone, for giving us the opportunity to host the session. And we hope to have you again on our platform very soon. Thank you so much.
Thank
Good
you.
night.
Good night.